centric study. The incidence and distribution of common tumors itself can be a good starting point.
So 30 seconds to go live.
Okay, dear.
Good morning.
That's Sameer. Hi, Sameer. How are you?
Hello, good evening, Dr. Sameer.
All the best.
We are live now.
Okay, thank you. So, good evening, friends, ladies and gentlemen, our esteemed faculty, and all the delegates from all around. We welcome you to the webinar. I'm sort of starting it a bit different. It's a slightly different day today. Delhi Orthopaedic Association has been doing these evening webinars for almost 6 months now. And we have also created a library on our website. The screen you see right now is the home page. And once you click on the library, you go to a page which archives all the webinars which have been done till now. So by the end of the month, even this month's webinar would be there. And once you click on a particular webinar, you will end up with that one, and you can go and revisit all the lectures which are done past. We've done these webinars keeping in mind both the requirement of our trainee residents as well as the practicing orthopedic surgeons, because as all fields, even orthopedics is evolving. So just to brush up with anything new which is coming in. So once you click the link, you go live on the Omniquest page, and then you can explore further and look into all the various details. So today we are doing this exciting webinar on pathological fractures. It's going to be a mix of lectures and case discussions. And we have a very, very strong faculty with lots of experience, dedicated orthopedic oncology faculty. And today's moderator is Dr. Vivek Verma, who is a senior consultant at Max Parpatganj. And he would be introducing the faculty further and taking on this webinar. For the delegates, they have a chat box, and we encourage all of you to put in your questions on the chat box. And we at this end would be taking up all the questions which are put up and try to answer to your queries. So thanks a lot on joining us this evening. And I hand it over to Dr. Vivek Verma to conduct today's webinar.
Thank you, sir. And good evening and welcome everyone. Today it's going to be another very exciting session on pathological fractures. And we all know that pathological fracture as such is quite a broad topic, and it is difficult to cover everything up. But today we have a mix of very eminent faculties from across India, and we have tried to cover it majorly. So today we have 3 lectures followed by case-based discussions. And I would like to introduce our faculties. We have Dr. Manish Pruthi, who is assistant professor and consultant at Tata Memorial Hospital, Mumbai. So he will be speaking about approach, because approach is something which is very basic and we all should know whenever we read any X-ray how to approach such tumors. More importantly, the other topic, which is if it comes to a certain histology, how do you manage it? So this was a very exciting topic because not much is discussed anywhere. Mostly we all, as orthopedic surgeon, we end up in the fracture fixations. But how the understanding of histology changes your treatment planning, your further prognosis, what do you counsel the patients? So we have doctor at Adyar Cancer Institute in Chennai, and a very good friend, and I hope it's going to be very exciting. Important point, that is about the pathological fractures in spine. Very commonly encountered by all of us whenever we are dealing with tumors. And today we have Dr. Abhishek Srivastava. He is senior consultant in spine surgery, and he will throw light on different etiologies and management principles in spine. Apart from our seasoned orthopedic oncologist, Dr. Akshay Tiwari, who is the director at Max Saket. Professor Dr. Arvind Jaiswal, he is also willing to come for our panel discussion. He is ex-professor AIMS and currently head of the department spine surgery at Max Vaishali. And I'll be your moderator today. So I think without much delay, we start with our first talk, which is approach to pathological fractures. Over to you, Dr. Manish.
Thank you very much, Dr. Vivek. It seems to be a very interesting topic, and I think it is very relevant for the orthopedic surgeons because more or less in our practice, we see a lot of pathological fractures. So I would like to thank the organizing team, Dr. Lalit, Maini, Dr. Vivek Verma, for inviting me here to deliver this talk on approach to pathological fractures. A very good evening to all my friends. Yeah, can you see my screen now?
Yes, yes.
Again, sorry for the delay. Yeah, so this is an X-ray of a 23-year-old girl who presented to a tertiary referral center, tertiary orthopedic center. With we had a primary bone sarcoma, which has been inadvertently nailed. So even if we go through the NCCN guidelines, it says an abnormal radiograph in less than 40 years, we should refer to an orthopedic oncologist for a biopsy. But when the patient age is equal to or more than 40, we have to think of a bone metastasis. And so basically we are thinking of a metastasis when the patient is above 40 and a primary tumor in less than 40. But there are rules to this exception, and we have to always consider primary sarcoma of bone. So what should be done if a patient presents with a pathological fracture? So this is the most important question to understand today. And the answer is the workup. So we cannot actually jump to a treatment of a pathological fracture without evaluating it further. The aim is to avoid our audit sarcoma because this is usually a very significant disaster in the management of a bone tumor. So what are the relevant questions that we want to answer in a pathological fracture is when do you suspect, then how to approach, the treatment plan, orthopedic management, role of bisphosphonate, exercise prescription and rehab, and the outcome. So last 5 topics will be covered by my dear friend Anand Raja in the next lecture. So my role today is to actually give you only an idea about how to evaluate and when do you suspect a pathological fracture. So coming to the first question, which is when do you suspect? And I think the most important thing is history, and the most relevant point in the history, that is what we see is a pain at the same site before fracture. So if any patient is complaining of a pain at the site of a fracture before it fractured, we usually know that there is some pathology which was going on, and that is how the patient has fractured. The other important history that you can get is an insignificant trauma, which is very relevant in a younger age group, but not very relevant in an older age group because we see that the osteoporotic neck femur or the intertrochanteric fracture usually also happens because of an insignificant trauma. So basically an insignificant trauma and a diaphyseal femur fracture in a young adult, definitely it should raise our suspicion for a pathological fracture. And a pain at the same site of a fracture also before a fracture has happened also should be like pointing towards a pathology in the bone. Also, we should be aware that in a patient who is more than 40 years, the chance that a pathological fracture is due to a carcinoma is 500 times more than a primary bone sarcoma. But still, a primary bone sarcoma can happen at this age. So we should not always think that we are dealing with only a metastatic carcinoma, especially if the patient is above 40 years. So going to the next question, how to approach? So approach has 3 components. First is history and a clinical examination. Second is a serological investigation. And then the radiological investigations. So, but like most of the orthopedic surgeons will argue, like we usually waste a lot of time in doing all these tests, like doing a serological test, doing a radiological test. And there should be a sense of urgency in fixing a fracture, especially in the lower rib, because this is what has been taught to us in an orthopedic management, like an intertrochanteric fracture ideally should be fixed within 72 hours. Am I wasting a time in evaluation because I am not fixing a lower limb fracture? I am risking it the patient to deep vein thrombosis or a pulmonary embolism or bed sores. And how does a fracture fixation of a fracture will harm my patient? Because anyway, the fracture needs fixation. So these are the usual questions that we think when we are evaluating a patient with a pathological fracture. And then we think we manage this like understand this as a like, am I actually wasting a time in evaluating this patient? But if you go through the first two cases that I have shown, the first case, which had a nailing in a pathological fracture, actually underwent a hip disarticulation because the all compartments were contaminated because of the nail. The second patient who was nailed in a high-grade sarcoma of bone required a total femur excision and a total femur replacement, which could have been easily managed by an intercalary section otherwise, just because he was nailed. And you can see that the nail was passing through the medullary canal and contaminating the full medullary canal from the tumor side. So, so basically, evaluation is very relevant. And as far as the history is concerned, we have to think of a primary bone neoplasm and a metabolic bone disease when the patient is less than 40 years. And we have to think of a metastasis or a myeloma when the patient is more than 40 years. If the patient has a previous history of cancer, then the most common site is GI tract, head, neck, and prostate. And then we know that more or less we are dealing with a pathological fracture. We also have to take the history of a sites of pain, the symptoms of visceral disease and organ dysfunctions, any other comorbidities, because that will eventually help in deciding the treatment plan, which Dr. Anand will be covering. As far as the examination is concerned, our focus should be on the local site, which is definitely the site of a fracture. But we should not miss the other painful side, because there could be other side which have an impending fracture, and I will be discussing the Mirel criteria for impending fractures later. We should be also evaluating the neurological deficits, if any, because a vertebral metastasis are also very common. A vertebra is also a very common site of a metastatic bone disease, which will be covered by Dr. Abhishek. We should look for signs of other organ dysfunctions and signs of primary malignancy, especially when the patient is more than 40 years, which could include a breast lump, an abdominal lump, or a liver enlargement, etc. So going to the lab investigations, which can help in evaluating a pathological fracture, especially when the patient is more than 40 years, is the calcium profile, like calcium phosphate, alkaline phosphatase level, LDH level, and immunoelectrophoresis with immunofixation, and serum PSA in males, and serum free light chain assays. So why these lab investigations are relevant is because PSA is a very specific marker for prostate cancer. And if it is elevated significantly, then we know that we are dealing with a pathological fracture because of a prostate malignancy. Similar is the case of a myeloma workup. The sensitivity of serum immunoelectrophoresis with immunofixation to detect myeloma is approximately 95%. And if we add serum free light chain assays, we can increase the sensitivity to 99%. So if a patient above 40 years presents with a pathological fracture, and I do these two tests, and I'm 99% sure that I have ruled out myeloma. So this is very relevant as far as that case is concerned. Similar is the case with the serological investigations, like this 12-year-old child actually recently presented to our OPD with a pathological fracture in the lower end femur. And patient had an MRI outside which showed a marrow infiltrative lesion. And as you can see, there was a small posterior soft tissue also. And patient underwent a biopsy outside, the review of which even at our institute showed a suspect a low-grade osteosarcoma, could be a parosteal osteosarcoma. But then as a clinician, we know that this was not fitting into the radiology. So what should be done in these scenarios? So the basic thing is, even our pathologist also mentioned, the discussion with the radiological finding is essential for whatever they are seeing. So the best thing is good to discuss. So this is a routine in most of the onco centers where we have a multidisciplinary tumor board. If these are not there, you can pick up a phone and call your radiology friends or a pathology friend that this is not fitting into my clinical picture. And that is what has happened in this case. When we discuss this case further in our multidisciplinary meet, we could see actually physial arrest lines in this, and we see a significant osteopenia. We reviewed the biochemistry. The alkaline phosphatase was significantly raised. The vitamin D was significantly low, and the calcium phosphorus was normal. So then, after discussing the case with the multidisciplinary meeting, we got an addendum in our report that it could be consistent with the reparative changes, including a fracture, as also mentioned in the radiological finding. So basically, it is very important to do certain serological investigations to rule out metabolic bone disease, to rule out metastatic bone disease, but we should not be wasting too much of a time in evaluating or doing a giving too much importance to certain blood investigation like basic tumor marker like CEA, CA 19.9. Another interesting case that I want to show here is this 15-year-old female. She also presented with a lytic lesion in the humerus. Radiologically, it appears benign. Patient had an MRI. Then in 6 weeks, the lesion actually progressed significantly and became more lytic and looks like more destructive lesion at this time. The patient again underwent an incision biopsy outside. And you can see the 3 different reports from a 3 different pathologists. One called it an osteoclastoma, second called it an osteosarcoma, and third called it as a giant cell rich lesions. So patient was thoroughly confused, and with these 3 reports, then she presented to us. We again repeated her serological investigation. Vitamin D was low, alkaline phosphatase was elevated, PTH was borderline elevated, and the patient was actually before coming only she was started on vitamin D supplementations. And when we repeated the X-ray, she had already fractured. We reviewed the pathology. It was a giant cell rich lesion. There was no malignancy. F3, F3A was negative, which was a specific marker for giant cell tumor. So basically, it is not a giant cell tumor. It's a giant cell rich lesion. And the lesion was healing and the pain was better. So with this kind of a scenario, we know that the patient has fractured because of some metabolic dysfunction, because of an osteopenia. And this is what has happened after 3 months. The patient had a well-healed lesion with no pain and the bloods are normal. So basically what I want to emphasize here is that not all pathological fractures are happening because of a malignant bone tumors or a metastatic bone disease. We have to keep in mind the metabolic bone disease also when we are evaluating a pathological fracture. And in this, serum calcium, phosphate, alkaline phosphatase are a very relevant markers. And then we have to go through our radiographs very well to understand whether we are dealing with a benign tumor versus a malignant tumor, because this points to a significant this gives a significant insight into our management plan. So basically these are the 4 common points in the radiology that we see whenever we see a bone tumor radiograph, that where is the lesion, what is the lesion doing to the bone, what is the bone response, and anything suggestive of histology, which is the matrix of the tumor. So where is the lesion? We see the type of the bone and the where actually in the bone the lesion is located, whether it's diaphyseal, metaphyseal, or epiphyseal. What is the pattern of destruction, whether it is geographical, moth-eaten, or a permeative destruction, or there's a pathological fracture which has happened because of the tumor. What is the bone response, which is a marginal sclerosis or an aggressive periosteal reactions? And what is the type of a matrix of this tumor, which are bony, cartilaginous, ground glass, or no matrix? These are the classical matrix that we can see, the classical example. So basically, our aim is to differentiate benign versus a malignant tumor when a patient presents with a pathological fracture in less than 40 years. And in more than 40 years, we have to do certain serological investigations to rule out myeloma and a metastatic bone disease, and then proceed accordingly. The only 2 tumors where I can say if a patient presents with pathological fracture and I'll be confident on radiology is a unicameral bone cyst and a fibrous dysplasia. So in these 2 conditions is the only thing where I will choose not to do a biopsy, and I'll be more very confident on the radiology to treat them non-operatively to splint them and not doing a biopsy first. Otherwise, all other lesions before doing an intervention, we usually recommend a biopsy, whether it is in less than 40 years or in more than 40 years of age. But there are 6 good reasons to not to go for a biopsy of the lesion first. These are the possible lesions, like it could be myeloma and biopsy is not needed, which I have already said that the serological investigations are 99% sensitive. It could be a primary bone sarcoma and requires better planning. I'll be covering this in the further imaging. It could be a vascular neoplasm and a biopsy can be catastrophic. We might find a more accessible site for biopsy, especially in patients with a multiple metastasis. Giving all relevant information to the pathologist is vital. And if you're planning a frozen section during surgery, a working diagnosis will definitely help us. So basically, this is another example, a patient who presented this. Actually, this is not a pathological fracture, but this patient presented with a lytic lesion in the acetabulum. A CT was done, which was showing a large lesion in the periacetabular area with the medial mass. And similar was the MRI findings. But our radiologists were good enough to pick that this could be a vascular neoplasm, and actually an MR angio showed an aneurysm from the internal iliac artery. So basically, sometimes a vascular neoplasm can also present with a large lesion, and we have to be aware of that. And that is why completing all relevant radiological investigations is very important before going ahead with a biopsy. So MRI of the end or the CT of the affected part is done when we are suspecting a primary sarcoma or a benign bone tumor. This is usually relevant in less than 40 years. And biopsy sites become very relevant, as I was talking, like in a proximal intercalcular total femur resection, which is required for a patient. We do biopsy through anterolateral approach, while for a distal femur resection, we prefer a biopsy through an anteromedial approach. So it is not like a patient presenting with a pathological fracture. My first thing should be putting a needle. It is good to do a MRI, complete our imaging, and then only plan the biopsy based on the final surgical plan. So going to the basic investigation that we do in above 40 years and the help that they provide us. So this was actually a very good paper published in JBJS on skeletal metastasis of unknown origin, which actually qualified how much these investigations can help. The history and physical examination in 40 patients helps only in 3 patients. The labs actually helped in 0 patients because they excluded or myeloma. The chest radiograph can help in picking a metastasis, a primary site in 17 out of 40. A bone scan actually has picked multiple lesions in 14 out of 40. A CT abdomen, pelvis, and chest has helped in picking another 11 patients, and biopsy only in 14 out of 40 patients. So basically, if you have a good workup plan, then you can find out overall diagnostic accuracy of almost 85% in identifying the primary site of the disease, especially in the patient who are more than 40 years. So with the inclusion and availability of PET CT scans at many centers, the previous published algorithms have more or less changed, because PET is very sensitive in identifying the site of disease as well as the primary organ. And usually the negative positive predictive value is almost like 93-94%. So PET is able to identify a primary site in 93-94%. So this treatment plan on orthopedic management will be discussed by Dr. Anand. So I will not be covering in this lecture. So basically, in a pathological fracture, if it is less than 40 years, what we are thinking is a primary bone neoplasm and a metabolic bone disease. And in more than 40 years, we are either thinking of a metastasis or a myeloma. And what we should be aware is when we are having a pathological fracture at one side, we have to see the other painful sites to identify the risk of a fracture there. And this is a very beautiful classification system given by Meral et al. And uh, it has been verified with various studies, and it is very relevant that we do the scoring of other sites to assess the risk of a impending fracture at those sites. And we have a scoring like a site of the disease, the radiographical appearance, the bone width, and the pain. These are the criteria that we see. And based on these criteria, we do the scoring. And if the scoring is more than 9, we know that the fracture is impending and requires a prophylactic fixation. And Ward et al. Actually found that the patient who had a fixation of impending fracture has a shorter hospital stay and have a more likely chance of to be discharged at home compared to nursing home. So we have to do a impending fracture assessment in the other bones because the patient has already presented to you with a pathological fracture. So to conclude, approach to a pathological fracture depends upon the age and the likely differentials, and fixation should be avoided till the histological confirmation is done. We have to have a pathology report, and the aim is to avoid a rhodid sarcoma. That is how I want to conclude. Thank you very much.
Thank you, Dr. Manish. That was a wonderful presentation, and you have just taken it into the flow. I will like to stop you here to answer a few questions put up in the chat box. So first question is from Dr. Abhijit, and he's asking, what is the relevance of increased gamma globulins other than the M band in serum electrophoresis?
Basically, there like a myeloma bone disease actually is a spectrum of bone disease. We have a gamma globulinemia of unknown significance also. Fine. So we have a smoldering multiple myeloma in which we are seeing sometimes and then it is disappearing. So basically, our aim here is to detect a clinically relevant multiple myeloma. Okay, so for that, doing an SIEP with immunofixation actually helps, and then the patient undergoes a bone marrow. All these patients will undergo a bone marrow, and then only we detect. So basically, once we have a pathological fracture, what we are discussing here is whether it could be because of a myeloma bone disease or not. It could be related to myeloma. In that, doing only an SIEP with immunofixation will rule out a myeloma in 95% of cases. And that is the only investigation that you need. If it shows a doubtful gammopathy, then a hematological evaluation is necessary. If it is normal, then 95% chance that you have ruled out a myeloma.
So for better understanding of orthopedic residents and our colleagues, so if we are suspecting a multiple myeloma, the investigations that are relevant is we have to ask for serum protein electrophoresis along with immunofixation as well as serum-free light chains, which increases the sensitivity. Just
to 99%, yeah.
To 99%. Just isolated, if we ask for serum protein electrophoresis, the chances are
so only serum protein electrophoresis, the sensitivity is 70% only. So we can miss 30% of myelomas. If we add immunofixation, the sensitivity goes to another 25%, goes to 95%. So I think when we are ordering an SIEP, we have to order an immunofixation along with it, because then we'll be very confident in ruling out a myeloma. This is very relevant if the patient is more than 40 years.
Yes. And just to summarize what you have said, that once we have to achieve a diagnosis, we have to have all the parameters correlated, because a very interesting case you had shown where there was a pathological fracture and biopsy showed a parosteal osteosarcoma, because there was a fracture and probably somebody biopsied the fractured area, which showed osteoid, and so the diagnosis of osteosarcoma is given. So I think very important point for all who are watching, that a proper correlation with history, clinical evaluation, serological blood investigations, with supported with our radiological workup, X-ray, MRI, and biopsy. If there is any discordance, then we have to revisit, discuss the case again, whether it is fitting with the diagnosis or not. One more question I have for you. What is the relevance of alkaline phosphatase?
Like that is why I have shown that case, because that child with a lower end femur pathological fracture, even without an X-ray also, we saw that the alkaline phosphatase was 3 times the normal. So that means definitely he's having a metabolic bone disease. Although the pathology report shows an osteosarcoma, but the alkaline phosphatase was so high that we thought it's a metabolic bone disease. And the radiology was then showing a classical physeal arrest line. So then we could actually decide upon that it is a metabolic or ricket rather than any other thing. But although the biopsy report was classical of osteosarcoma. So alkaline phosphatase is very relevant in the situation of metabolic bone disease. And same was the other girl with the proximal humerus fracture. Her alkaline phosphatase was also low. And many of the time you see because of a low vitamin D levels. So that is what we are seeing very often. And all these biopsies are actually looks very aggressive. Both these lesions, biopsy showed an osteosarcoma.
Okay. Another case you had shown where you said that there were 3 different pathological reportings. So what do you suggest when we do a biopsy? What is the ideal principle? Should we divide and send the sample to 2 different good labs, or it should be sent to 1 lab? Because very commonly, even when I'm practicing, if there is a case referred from some orthopedic surgeon, they ask me that just send 1 sample to this lab also. So what is your take on that?
So that is very clear cut, that we cannot divide our sample. Okay, whatever sample we take out, we give it to 1 lab and let them report, and then take the blocks from that lab if we are not happy with the report and get it reviewed here. But our problem is not that, Vivek. I feel our main problem is that even if we have done that, we have got 3 different reports. Okay, we have not divided our sample, but still we got 3 different reports. Then how to manage that? So I think that is what our pathologist at Tata Memorial, Dr. Jambekar, used to say, that it's like a jigsaw puzzle. Everything should fit. And that is why I have covered the radiology also here, that the radiology, it is showing a benign tumor with narrow zone of transition, no periosteal reaction. Pathology is showing a malignant lesion. So it is not fitting. So basically, we have to see that the radiology, the history, the pathology, everything is fitting like a jigsaw puzzle. And then only we can actually have a working diagnosis. If something is not fitting, that means something that is we are missing. Yeah.
Right.
So that is very relevant.
Fine. That was very interesting talk. And probably once we have more questions, we'll come back. So
Can I put a question here?
Sure, sir.
Very relevant talk and
Yes, sir.
very done, Manish. To you and maybe to other faculty also. Do we have any definitions for what is a pathological fracture, or it is still a clinical definition?
Dr. Manish, you would like to take? Or?
Definition of a pathological fracture.
So, okay, sir. I'll say when I thought of this topic, I read a bit about pathological fracture. So basically, whenever there is an underlying disease that weakens the bone, causing fracture, then it is called pathological fracture. Synonymously, some other terminologies are also used, like insufficiency fracture or fragility fractures. So broadly, when we talk in general, it includes all these factors also. But when we talk specific about diagnosis, insufficiency fractures include those fractures which have happened due to trauma, which would generally not cause a fracture in a normal bone. So ultimately, there is some pathology which is underlying, and mostly this pathological fracture terminology includes tumor commonly, or infections, or even osteoporosis. So I think this is few terminologies are synonymously used. Probably that answered your question, sir.
But I think, sir,
there's
you can answer
there's also one more definition. Like there is the National Cancer Institute of the United States. It's got a repository of definitions of various terminologies. So if you look at the NCI website, the National Cancer Institute defines pathological fracture. It's a very simple definition. It's just a one-line definition. It says it's a broken bone caused by disease. So if there's an underlying disease in the bone and that is causing the fracture, that's called as a pathological fracture. However, they add one more line to say that it's a broken bone caused by disease, often by spread of cancer to the bone. So that's how, if you are looking for a definition, that's how the NCI defines a pathological fracture.
I would like to add, the fragility fracture is actually probably a subgroup in the pathological fracture for most likely, osteoporotic or, because of metabolic bone disease, if there is a fracture happening, then that is possibly the reason, that is how they define most of the time.
See, our problem that we face is osteoporotic fracture in a young adult as compared to an osteoporotic fracture in an elderly. Because in elderly, our management plans remains the same. But in young adult, we are got often confused with the primary sarcoma of them. So in an elderly, 60 years, in a fragility fracture and osteoporotic fracture, we are not very worried because our treatment remains the same. But in a young adult, the treatment is actually totally different. We might not operate, we might not fix, we just correct the metabolic condition and the lesion starts healing. So that is where the definition and the management actually comes into. But I agree that the pathological fracture is the per se, it's a word only. Pathology, which is causing a fracture in the bone. So I agree with Dr. Anand, like anything which is weakening, which is affecting the bone.
Do you feel, all of you, that stress fracture would be included in a pathological fracture? Like the marchers getting a neck or femur fracture due to repetitive stress, or it's a gray area?
So I don't think so, because that is a stress because of a repetitive trauma rather than the pathology in the bone. It is basically a repetitive trauma. It is like a traumatic fracture, but a chronic trauma rather than an acute trauma.
Thanks a lot. I think that would clarify a lot of thoughts in many delegates who would be wondering on this. So Vivek, you can take further if there is any question.
Right, sir. So next, I would like to invite Dr. Anand Raja for his talk. Over to you, Dr. Anand.
Thank you.
Dr. Akshay has joined. Welcome, Dr. Akshay.
Yeah, so is my screen visible? And I will just put on the full screen.
Yes, it's visible.
Yeah, so a big thanks to the organizers, Dr. Akshay, Dr. Vivek, Dr. Lalit. Thanks to the Delhi Orthopaedic Association for inviting me here. I mean, it's really a tough job. Dr. Manish is always so good. To follow Manish, Dr. Manish is a really good job. But in a way, it's also good because he's kind of set up the stage. He's laid the foundation, and that probably makes my task a little bit easier. So a disclaimer here: I'm not an orthopedician. I'm a surgical oncologist with a passionate interest in orthopedic or musculoskeletal oncology. So this talk is not going to be I'm not going to try to teach an orthopedician how to fix a fracture, when to fix it, when not to fix a fracture. This talk is not going to be about the technical details. Talk is not going to be about how to rehabilitate a patient after the fracture is being fixed or the joint is being replaced. This talk is not about that. What this talk is about is an oncologist perspective into primary and metastatic bone cancers or bone diseases, and how to approach, what would be the approach to treatment. So that's all this talk is going to be about. So, like Dr. Manish very correctly said, we always remember the horse and the cart. The horse is always in front, the cart is always behind. It's not the other way around. We don't put the cart in front and the horse behind. So, if we are faced with a fracture and if we suspect a pathological fracture, we always have to first diagnose whether it is a pathological fracture, what is it that led to the fracture. If it's a traumatic fracture, please go ahead and treat it. You've diagnosed it as a traumatic fracture and treated it. If it's a pathological fracture, please wait, diagnose it, and then treat. Diagnosis always comes before treatment, not the other way around. Uh, Pathological fractures occur secondary to altered skeletal physiology and mechanics in the setting of benign or malignant lesions. This just answers what Lalit Maini had asked just now. Proper diagnosis, staging, and treatment of pathological fractures are paramount and essential to improve patient outcomes. So, just a brief view of what we usually see, the spectrum of patients that we see. Some of the slides might be repetitive because Dr. Manish has already spoken about it. So I'll try to fast track that. A 20-year-old boy comes with complaints of pain and inability to bear weight after trivial trauma. This is the pre-op X-rays that was done. So, the patient went to an orthopedician elsewhere and, the fracture was fixed. The biopsy was also done. The biopsy is osteosarcoma. Now what next? Again, a 58-year-old gentleman was diagnosed to have a thyroid cancer, presented with complaints of pain in the thigh. He was already diagnosed to have thyroid cancer, was at home, had a fall, had a fracture, went to an orthopedician outside, and the fracture was fixed. Now, do you have any insights as to whether this is appropriate treatment? Is a metastatic bone disease? We don't know whether it's a metastasis or not. What are the sites of metastasis? Number of metastasis. So this begets the question: is this an appropriate treatment for this patient or not? A 17-year-old boy with complaints of pain in the upper arm underwent curettage with placement of intramedullary nails. So this is how the patient came to us. This is the intraoperative picture where we managed to salvage the limb. But you can see this huge scar. You can see all these multiple pin marks. Now the biopsy report for this patient was osteosarcoma. Do you think that justice was done to this patient by trying to fix the fracture and everything else? So again, a 33-year-old gentleman, you can see here bone cement. There was some lesion in the proximal tibia. Curettage done. The black spot that you see there is the bone cement. The biopsy was an osteosarcoma. Again, an intraoperative picture. Again, do you think that right things was done by this patient or not? How are these? How could we have avoided all these things? And what are the implications of histology? If this is an osteosarcoma, what if this was a metastatic breast cancer? What if this was a metastatic lung cancer? What if this was a thyroid cancer? These are the things that we try to answer. Again, the significance is save the limb. Inappropriate treatment is not good. Delay in diagnosis with consequent detrimental oncological outcome happens. And if we treat it inappropriately, we open ourselves to legal issues. Objectives of treatment are identify, beware. Beware also means be aware of pathological fractures, diagnosis, staging workup, surgical approach to treatment, and the most important is multidisciplinary care. The photograph that Dr. Manish showed when everyone sits together and decides, the importance of that cannot be overemphasized. I think clinical symptoms and all, I think is already spoken, so we'll go. So, like I said, beware, because even lesions that apparently look benign uh, can turn out to be problematic later on. So this was a patient that had this lesion for which a curettage and a bone grafting was done, presented to our institute after the bone graft. We reviewed the slide, everything else was done, which was suggestive of desmoplastic fibroma, kept the patient under observation. These are the serial X-rays. I don't know if you can make out on the X-ray on the right side. There is some lytic lesion there that is seen there, some disease which was missed by us also at 2.5-year follow-up. The patient comes back, defaulted into 1 year with this huge lesion, biopsy of a high-grade osteosarcoma. The consequences can be many. There are consequences of under-treatment. The same way there are consequences of over-treatment as well. The lesion that you see here in the shaft of the femur, this was actually a metastatic carcinoma from the kidney. This was a solitary site of bone metastasis. These needn't have to be nailed the treatment of choice for this patient would have been resection. So the implications, as Dr. Manish said, it's not only that by when you ream the marrow, it's not just that you've contaminated the entire bone from top to bottom. It's also that you ream under pressure. And when you ream under pressure, what basically happens is there is dissemination of tumor cells from the site of the fracture into the bone marrow, from the bone marrow into the blood vessels, and possibly not only increasing the risk of local recurrence, but also the risk of systemic recurrence. Again, there's this patient here who had a survival of about 3 months, CA breast, extensive disease. Someone has gone and replaced the proximal femur. I mean, this is a consequence of overtreatment. If you knew what the primary was, if you knew what the outcome was, I mean, you probably didn't need to go and replace the entire femur, especially considering that the survival was only 6 months. So both under treatment as well as over treatment have to be avoided. I think in the index of suspicion, Dr. Manish has already spoken. I'll skip this. Again, a bone lesion with an unknown etiology, it is better to treat it like a bone tumor, either a primary bone tumor or a metastatic bone tumor, until proven otherwise. Always stop, think, and stage the disease. The action should be the last part of the intervention. The primary bone and the metastatic bone disease, I think again, Dr. Manish has already spoken about this. I would just like to emphasize only one point here. When you deal with metastatic bone disease, always look at one, what are the number of what is the site of bone metastasis, how many on the axial skeleton, how many in the appendicular skeleton, how many on the weight bearing areas, the site and the number of visceral metastases. These are paramount because this will help to prognosticate the patient, and that defines therapy. I'll come to that a little later. And like I said again, the multidisciplinary team is invaluable. What happens? So the pathological fracture is broadly divided into three. Pathological fracture because of benign bone disease, pathological fracture because of primary malignant bone cancers, and pathological fracture because of metastatic bone disease. So benign bone diseases with a pathological fracture are usually managed based on one, histology, what is the primary that you have, and the extent of bone destruction, and what would be the healing possibilities that you have here. Here we see that we have an ABC. The patient was initially offered sclerotherapy. The patient had 3 or 4 injections, but then fell down, had a small sustained fracture, and then subsequently also had sclerotherapy. So it is paramount to go and fix this because he sustained a pathological fracture, was in severe pain, could not bear weight, was in severe pain. So you can't just keep giving sclerotherapy, needs an intervention. What about a chondroblastoma? Again, if you see here, the medial cortex of the femur is fractured. On the MRI, there was a soft tissue component there. So the easier thing is go ahead, curettage all that. Patient was in severe pain, unable to abduct the arm. So go ahead, curettage everything, burr everything, put in bone cement, and then came out. So chondroblastomas as benign bone tumors could be done that. Same way here, as you see here, there's also a giant cell tumor. I'm sorry for the mix-up of the photographs. There was a giant cell tumor. Again, there was a pathological fracture. There was a lot of soft tissue component. We went ahead and curated the lesion. You can go and fill it up with. We fill it up with bone cement. A lot of other people fill it up with bone grafts. That's a treatment for giant cell tumor. On the other hand, you also have these giant cell tumors that are like too huge, but there's a break everywhere else. So these cannot be curated. So these have to be dissected. Again, like finishing the spectrum of benign bone diseases, that really depends on one, histology and the extent of bone disease and what would be the possibility that the disease will have. Coming to osteosarcoma. So this is a patient that again presented to us, a 17-year-old gentleman with a frank pathological fracture here, as you can see. The second image shows the post-chemotherapy image. The post-chemotherapy image, you can actually see that along the medial border, there is some suspicion of bone healing because there is some ossification. But on the MR here, you could also see, and clinically, there is actually increase in size of the tumor, extensive soft tissue component. So even after neoadjuvant chemotherapy, this patient could not be salvaged and had to undergo amputation. The relevant point here is just because it was an osteosarcoma, we did not go and amputate it. Pathological fracture, in the years or the decades gone by, was an absolute contraindication to limb salvage. However, it is not so right now. These patients have to be offered a trial of neoadjuvant chemotherapy. see whether the fracture heals or not. And based on that, you can offer local therapy. Again, one more patient here who has, you can probably see in the anterior cortex, there's a small fracture there in the anterior cortex of the femur. Patient got neoadjuvant chemotherapy. There was very good bone healing, good shell of ossification, subsequent to which patient underwent limb salvage surgery. So, what are the implications for a pathological fracture in osteosarcoma? Again, a very good paper from the Journal of Bone and Joint Surgery. So, it said that the performance of limb salvage surgery in carefully selected patients with pathological fracture does not significantly increase the risk of local recurrence or death. The important line here is, in carefully selecting these patients. So most of these patients, we would just give them either traction or don't do anything at all. Give them neoadjuvant chemotherapy. Look whether the fracture heals or does not heal, and then take a call on limb salvage surgery. Again, the cooperative osteosarcoma study group, one of the largest groups which conducts lots of studies on osteosarcoma, analysis of about a little less than 3,000 patients. Their data suggests that pediatric patients with pathological fractures in osteosarcoma should not be treated any differently from those without pathological fracture. Their study shows no difference in overall survival or event-free survival between patients with or without pathological fractures in this age group. So this is as far the data from the West is concerned. What about Indian data? What does the our own data from the Adyar Cancer Institute? We reviewed all our literature from 2000 to 2018, 19 years data, all primary osteosarcoma of the extremities who received local surgical therapy, all ages, both localized metastatic disease, treated with curative intent, where all the reports were available for follow-up. Roughly about 400 patients met this inclusion criteria. 51% of them had pathological fracture or developed pathological fracture during neoadjuvant chemotherapy. So these 51 patients with pathological fracture were compared with 347 without. Um, 39 patients, 39 of these 51 had pathological fracture at presentation and 12 developed during the course of treatment. All patients were managed with non-operative immobilization. Of the 30 for whom the data regarding fracture union was available, 18 achieved union and 12 did not. And 28 of these patients with pathological fracture group underwent amputation, 23 were offered limb salvage surgery. So that's a fairly high number, a little less than half of these patients who would otherwise have been deemed inoperable and would have been subjected to amputation were offered limb salvage surgery. Local recurrence again was not very significant, was observed in 7 of 23 patients who underwent limb salvage surgery. As expected, none of the patients who underwent amputation had limb salvage. This was, however, not statistically significant. 13 patients among the amputated group developed systemic recurrence, while 12 patients developed systemic recurrence. Again, no difference in either local recurrence or systemic recurrence. And there is no difference. Again, we don't have to go into the numbers just to say that the local recurrence, systemic recurrence, and the 5-year overall survival or disease-free survival was no different between the patient who underwent who had pathological fracture and did not have pathological fracture. For the pathological fracture, if they were treated appropriately with either limb salvage or amputation, all the three groups had similar local recurrence, systemic recurrence, and overall survival. So this concludes us. The conclusions that we drew from the study were pathological fracture was not shown to be a prognostic indicator for overall survival or disease-free survival. When we say disease-free survival, we mean either local recurrence or systemic recurrence in extremity treated osteosarcoma patients. The presence of pathological fracture does not increase the risk of recurrence. What about Ewing sarcoma? Do pathological fractures influence survival and local recurrence? Again, a very good paper published in Cancer. If we look at that, there were more than half of the patients for Ewing sarcoma. The same principles of surgery apply for Ewing's as for osteosarcoma. Most of them are subjected for non-operative intervention for the duration of the neoadjuvant chemotherapy. Again, you can see here there is some loss of the medial cortex here. The subsequent X-ray, which I don't have, also showed that there was progression after this, after which the patient came to the hospital, got neoadjuvant chemotherapy. Post-op X-ray showed good bone union, subsequently underwent limb salvage surgery. So, suffice to say here that whether it's benign bone disease or metastatic bone disease, with benign bone disease, treat according to the extent of disease. If it's a metastatic bone disease, especially osteosarcoma and Ewing's, give neoadjuvant chemotherapy, look at the response, look at the site of the primary. And if you could see if you remember the photograph for which the proximal humerus, there was a big scar along with multiple names. Even those type of lesions we could salvage. Even the photograph, if you remember what Dr. Manish showed us for the total femur, some of these patients we are still able to salvage but it's preferable if you don't fall into those lesions, into those kind of lesions. Give a trial of neoadjuvant chemotherapy, see if the fracture heals. If it heals and the tumor size decreases, you can always try neoadjuvant, limb salvage surgery. Coming to metastatic bone disease, skeletal metastasis is really the third most common site of metastasis. Dr. Manish Pruthi said, at that susceptible age group, if you have a pathological fracture, there's 500 more the chance that it's because of a metastasis is 500 times more as compared to a primary bone disease. The commonest sites of metastasis usually are either the thoracic spine, ribs, pelvis, or the proximal long bone. These are the least common, but they are all very important. And the bone metastasis may cause either pain, inhibition of function, or decreased quality of life. Uh, about 10 to 30% of patients with metastatic bone disease will experience a pathological fracture with femur as the commonest site of the fractures. And again, important here to remember that there are five basic histologies. If you come from top to, I have not enumerated this in order of frequency. I've just enumerated it from, if you go from top to bottom, these are the five malignancies that have the commonest risk of metastatic bone disease and also the incidence of pathological fractures. They are thyroid, breast, lung, renal, and prostate. So how do you evaluate these patients? So evaluation does not just mean an evaluation of the metastasis. You should also evaluate the evaluation of the primary is important. Also, evaluation of the secondary is important. The evaluation of secondary would mean not just the metastatic site in the bone, but all other metastases in the bone, all other sites of visceral metastasis. Stage the disease properly. See how many sites of parenchymal disease is there. That would help us to come to the diagnosis. The 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 big points that we usually keep in metastatic bone disease when we plan treatment and evaluation are: what is the general condition of the patient, what is the site of primary, what is the stage of the primary, what are the sites of metastasis, regional nodes, non-regional nodes, what are the sites of visceral metastasis, bone metastasis, the number of metastasis. Again, a very important distinction. We keep talking about solitary metastasis and single metastasis. We need to know the difference between the two. When we say single metastasis, it means that there is one metastasis in one organ. Like, for example, if I say that there is a single liver metastasis, it would mean that there is one metastasis within the liver, but there could be other metastasis at other sites. For example, the patient from an RCC could have multiple bone metastasis with a single liver met. So when we say single, it just refers to one organ, irrespective of the number of metastases at the other sites. Whereas when we say solitary metastasis, it just means that the patient has got only one metastasis. We say that there is a patient with a CA, with a renal cell carcinoma with a solitary bone metastasis. It means that there is only one site of metastasis in the entire body, which is in the bone. The distinction is very important. We have to stage, and we have to not only stage. It's just not sufficient to say patient has got T1, T2, T3, T4. You have to stage it, you have to stage, group it, and then prognosticate it. Treatment then comes subsequently. The most important factor when we treat metastatic bone disease is, in addition to the metastasis in the bone, what is the availability of effective systemic therapy agents. The more and more systemic therapy agents are available, the more and more is the longevity of the patient, more and more the longevity that directly influences the type of treatment that you would give to the bone. And most important, which we can't neglect here in India, are cost. These are some of the things that should be running at the back of your mind as soon as you start evaluating these patients, and not think about it, at the very fag end. Um, I'm reiterating this point again and again, but the discussion in the MDT regarding the sequence of treatment, the surgical options, the non-surgical options available. I mean, this is paramount. No decision should be taken without involving everyone for optimal patient's outcomes. Uh, Evaluation of metastatic bone disease. Dr. Manish has already spoken quite a bit about this in perfect detail. Suffice to say that in today's day and age, most of these patients would undergo a PET CT scan, which could possibly reveal the site of primary. When will you biopsy a suspected bone metastasis? So, if a primary carcinoma is unknown, you could biopsy. A biopsy could be undertaken to exclude a primary bone lesion. When a histological confirmation of a metastatic disease is needed, if there are multiple, if there are more than one histologies, or if there is a solitary bone metastasis. If you have an RCC with a solitary bone met, you don't know what the lesion in the bone could be. It could be a met, it could be anything else. If there's a single disease in the bone, you need to biopsy it before you treat it. You need to biopsy it when the clinical and the radiological features are in doubt. And the possibility of new bone of a new primary bone tumor or an already existing primary bone tumor with a metastatic bone disease is there. These are the situations when you would want to biopsy a suspected bone metastasis. How to do the biopsy? I think Dr. Manish has already spoken about it. Usually, we either do a bone marrow aspiration, a treatment biopsy, or usually a gem shedding needle biopsy, which can either be blind or CT guided. Coming to treatment of these patients, there are three ways to treat: prevent, cure, and palliate. We are not going to the preventive aspects of it. The ultimate goal of musculoskeletal treatment of skeletal metastasis is to get the patient back to his or her previous level of function, if possible, as soon as possible. The skeletal metastasis by itself is seldom dangerous or life-threatening, and the treatment will most likely do nothing to the primary disease. The maximal the treatment should maximize functional independence and quality of remaining life to the patient. Four basic considerations: pain relief, preservation of function, skeletal stabilization, and local tumor control. These things I've already spoken: site, location, number of bone metastases. Again, important to remember here is most patients who have pathological fracture due to uh, who have fractures due to a pathology will very rarely have neurovascular or joint involvement, because the bone would already be weak and it would fracture, and very rarely the impact would be so violent that it would go on to cause vascular or neural compromise. Surgery for bone metastasis is really brought into two. Will you resect or will you fix? Resection should be offered only when the intention of treatment is either potentially curative or for some reason you cannot fix the bone. For most other situations, fixation would be the option. Uh, the patient should survive the operation. The advantages are he can have immediate weight bearing. Implant survival, one should be more than the patient survival. If at any point in time you think that the patient survival is going to be, if it's going to be the opposite side, don't fix it. All post-operative patients require, if you fixed it and the survival is otherwise good, most of them would require irradiation. If you are going to irradiate it, you should irradiate the entire fixation device, the entire bone uh, that is involved. And very rarely preoperative embolization may be needed in very vascular tumors, mostly thyroid and renal cell cancers. Again, a small thing about what we keep talking about: synchronous metastasis, metachronous metastasis. Just a brief primer about what these terms mean. Synchronous metastasis means the diagnosis of the metastasis within 6 months of the interval of the diagnosis of the primary. It is not the end of treatment of the primary. If you have diagnosed a primary and within a 6 months you diagnose a metastasis, that is synchronous metastasis. If you diagnosed a primary and 6 months after that, if you diagnose metastasis, that would be called as a metachronous metastasis. Really, now coming on to the meat of the topic, we'll be basically talking about these 4 or 5 more malignancies that usually metastasize to the bone. Coming to renal cell carcinoma, no need to go into detail about all this. Just to, this table is just to tell us that there is, whenever you have a renal cell cancer, so this is now assuming that, patient is presented with a pathological fracture in an age more than 40 years, and we've evaluated in every way that Dr. Manish has said, you evaluated and you've come to the diagnosis that patient has got a primary in the RCT and now has got a bone metastasis. The entire talk will follow, that algorithm. So just to say that when patients have renal cell carcinoma, there is a scoring system available which tells us, even in metastatic setting, what is the favorable, unfavorable histology, favorable risk, intermediate risk, or poor risk. So, the best way to teach is to have clinical case scenarios. So RCC with bone metastasis itself is not sufficient. Let's say there are multiple case scenarios. There's a 35-year-old gentleman who was diagnosed to have a mass in the upper pole of the kidney with a synchronous lytic lesion in the body of the D11 vertebra. There is a 60-year-old lady diagnosed to have a tumor in the midpole of the kidney, occupying almost the entire kidney, with lytic lesions, with multiple lytic lesions in the clavicle and the femur, both femurs. A 43-year-old gentleman with presenting with a mass in the right kidney with multiple lung metastasis and a solitary lytic lesion in the neck of the femur. How would you manage these patients? A 43-year-old gentleman with a history of nephrectomy, done a few years back with increasing pain and possibly also a small fracture, the proximal femur. How would you manage these patients is the meat of this talk today. So to answer these questions, what we need to know is that overall, as the number of bone metastasis increases, the survival also decreases. Patients with one compared to 2 to 5 or more than 5 metastasis have median OS that is consistently decreasing. Bone metastasis in the presence of concomitant other metastasis have shorter survival. Patients with a solitary site bone metastasis, remember the word single and solitary. Patients with a solitary site bone metastasis often have better overall survival than patients with concomitant or multiple site bone metastasis. Patients with solitary site bone metastasis have a 45% lower risk of death as compared to patients who did not have a solitary site, either a single bone metastasis or bone metastasis with other visceral metastasis. So that gives us an idea about solitary compared to multiple, 2 to 5 versus bone versus parenchymal metastasis. So if you group these patients according to good, intermediate, and poor risk groups as determined by the MSKCC score, the good risk had 43 months, the intermediate 22 months, and the poor risk 7 months. On multivariate analysis, concomitant metastasis, that is metastasis at multiple sites, remains a predictor for poor prognosis. Whereas good MSKCC score, radical resection for solitary site bone metastasis had good overall survival. In patients with bone metastasis, those who undergo radical resection had a 32% lower risk of death. Metachronous metastasis in RCC, specifically more than 1 year or of DFS, had the best metastasis, had the best survival. And really, all this is being brought about because after treatment of the primary, you also have multiple options of treatment, which include tyrosine kinase inhibitors and immunotherapy. Again, what would be that we look into this patient, general condition, imaging, what is the histology, whether it's clear cell, non-clear cell, hereditary or sporadic, site of metastasis, solitary versus single. So if we have all this information with us to answer the clinical cases that we said is really very easy. The 35-year-old gentleman with a renal mass with a solitary lytic lesion in the body of the D11 vertebra. What could you do for this? If it's possible to go ahead and resect and do a spondylectomy and come out, it's the best to do it because a spondylectomy is an R0 resection of the primary and an R0 resection of the kidney, and you render the patient potentially disease free with the maximum chance of survival. But this is in the spine. Not many patients would have the option of spondylectomy, whereas there is disease outside the spine. Mostly this patient would have radiation done. So that answers itself. The 60-year-old lady with a tumor in the midpole of the kidney with multiple lytic lesions in the clavicle and femur, like we said, 2 to 5, multiple sites of metastasis, the prognosis drops. So until and unless if the patient has got a pathological fracture of the femur here, all that you need to do, you know that the patient is not going to survive for a very long time. All that you need to do here is you need to fix the pathological fracture rather than treat it with curative intent or resect the metastatic site and replace the bone. You probably don't need to do that. You just need to fix the fracture. Again, this 43-year-old gentleman who had multiple lung metastasis with a solitary neck in the femur. Again, from the data that we just saw, we know that visceral metastasis with lung metastasis, that's probably got the worst survival. The solitary lytic lesion in the neck of femur, you see, based on what Dr. Manish again said, what is the risk of pathological fracture? If the Mirrell score is less than 8, the risk of fracture is very minimal. You could just give radiation if the patient has got pain and do nothing else. If the lytic lesion is a small fracture is there, then all that you need to do is just do a hemiarthroplasty because the patient is not going to survive long. Or, the question answers itself. The 43-year-old gentleman with history of nephrectomy with increasing pain in the right in the right kidney with a solitary site of bone metastasis. 2 years back he was done. We know that more than 1 year has got very good survival. So what you need to do here is to resect the bone and resect and replace the bone. That's got the best chance of survival because you've rendered the patient potentially R0, potentially disease free. Again, an example of what we had a patient with a RCC who presented to us 3 years down the line with a lesion here in the neck of the femur. With a sickness, one more lesion was there down in the diaphysis. So we resected the bone, and he's doing well. 2 years after the surgery. Yeah. Coming to thyroid cancers, again, this is very, very important. You can just forget these slides. Uh, Important just to know here that for most malignancies, we talk about 5-year survival. The prognosis are well different. Again, I'm not going into the anaplastic and medullary thyroid cancer, commonest thyroid cancers. Just suffice to say that most cancers we talk about 5 and 10 year survival. The well differentiated thyroid cancers, we talk about 10 years to 20-year survival. So most of these patients who have metastatic thyroid, we usually treat with iodine therapy. Again, we'll just spend a little bit of time. You can forget the slides that are there and just listen to what I have to say. Iodine therapy is iodine 131. It has got both beta rays as well as gamma rays. So the gamma rays are diagnostic, the beta rays are particulate, so they are therapeutic. I'm so sorry. I think there's a lot of disturbance on the line. So the dose. So whenever we have iodine therapy that needs to be given for the bone, for a metastatic thyroid, we need to remember. We need to see what is the site of bone metastasis, what is the number of bone metastasis, what is the number of bone. I, I think there's someone else also talking. There's a lot of disturbance on the line. Uh, uh,
Dr. Atul Vash, could you please mute yourself? Dr. Atul Vash is unmuted. Yeah, thank you.
yeah.
Please.
So when we talk about iodine therapy for bone metastasis, always remember again the number of bone metastasis that we spoke about. Just a little bit about iodine therapy. Iodine is usually 131. The beta rays are because they're particulate are produces the kill factor. The gamma rays are diagnostic. Over a lifetime of a patient, you can give for one individual over a lifetime, you can give only 1000 millicurie for a patient, which is basically one curie. So that's the dose of iodine that you can give over a lifetime for one patient. So how do you use iodine therapy? So you have to see, because if you have the dose that you need to give for bone metastasis, if a patient has got, say he's got a solitary bone metastasis, it is better that you go and resect the bone. If you have one site or two sites or even possibly three sites, it is better to go and resect the bone and replace the bone at whatever site. Why? Because you going to use this iodine therapy. If you resected the bone and there is only bone site of disease, you are going to keep the iodine as a reserve for later on. Why is that so? Because among all the metastases, iodine for bone that needs the largest dose. Lifetime is 1000 millicurie. But if you have to give it for a bone metastasis, you need to give up to 200 millicurie is the dose that is needed. For 1 to 2 metastasis, if there's going to be a large metastasis, the metastasis is not going to disappear with a single 200 dose. You'll give a single 200 dose, and maybe 4 or 6 months down the line, you'll give one more 200 dose. So 4 to 600 millicurie you've already exhausted in treating one or two sites of bone metastasis. And what is left for the patient? And you know that you are talking about 20-year survival. What if he develops a metastasis elsewhere in the lung, in the liver, which you cannot treat? You've already taken away that iodine reserve for that patient. So if it's a solitary bone metastasis, one or two or three sites of metastasis, it is better to one go and resect it. The reason that you are resecting it is one, you are keeping the iodine as reserve for later on. And second, even if you are giving lower doses of iodine, there's always a little bit of marrow toxicity associated with it, and you are sparing these patients of marrow toxicity. This, however, applies only for if there is going to be oligometastasis. When we say oligo, the number is not defined. Usually, people mean anything between 2 to 4 is what they mean by oligo. So again, like we said, there are multiple settings in which we can discuss this. The patient has got non-metastatic disease at presentation, but the whole body scan is positive. There is one solitary site. Patient had metastatic disease at presentation. So we'll deal with this as and when we go along. So non-metastatic disease at presentation, but the whole body scan is positive, shows one site in the femur. What would you do? The answer, again, based on the discussion that we know, is very clear. You go and resect it. Patient at presentation with bone only metastasis, 1 to 2 sites. What would you again do? Go and resect the bone, even both the sites. That's it. Patient is metastatic at presentation with multiple visceral. What would you do? There is no point in going and resecting these metastases because he anyway needs iodine therapy for treatment of the visceral metastasis. He's also got multiple bone. So don't do anything for the bone until unless there is an impending fracture, which you can go and fix the fracture. but you are not going to give curative resection for the bone. Just fix a fracture if there is a pathological fracture, and treat with curative intent with the iodine therapy. The patient has got non-metastatic disease at presentation, but with metachronous metastasis, again, multiple bone and viscera. How would you treat exactly like how you treated the above? If there's a pathological fracture, just fix it. You are not going to do a curative resection. Single bone versus multiple bone, there are various numbers that people quote, but in my opinion, based on our experience, the maximum that we've resected for only bone metastasis is 5. So that's the number that I go with. So again, if you can see here, a patient presented with isolated clavicular metastasis, which was resected. The patient is doing very well. Coming to lung cancer, again, important.
Dr. Anand, sorry to interrupt. Just a reminder, we have to finish.
Yeah,
don't do this.
yeah, I'm just finishing here. Just two more lines here. Again, lung cancer here with improvement in quality of life, with improvement in adjuvant therapies, the prognosis for lung cancer has really zoomed from little less than a month to from 10 to 15% to 40 to 45%. Oligometastatic disease and oligoprogressive disease are there. For most of these patients will require only, because metastatic lung cancer will usually have extensive metastasis. Oligometastasis is very rare. Most of them will require only fixation. But if the patient has got only one site of disease compared to nothing else everywhere else, you are very well, you can go and resect it and come. There is also this thing called oligoprogressive. When you say oligoprogressive, it means that there is all the other sites of disease are under control, or they are all disappeared, but the disease is progressing only at one site. So if the same was an oligoprogressive, every other site is under control, but this is the only site, I will not fix it because this is the only site that is progressing. So I'll probably resect it and treat it with curative intent. So you really have to titrate all these things. Myelomas, I think enough is spoken about. We'll really not go there. For breast cancer, again, most breast cancers to treat with curative intent pathological fracture is really rare, because even if you have oligo sites of metastasis, one or two sites of metastasis, they're usually systemic therapies to begin with. Most of them will require only fixation. However, there is the very rare scenario where you might have a solitary site of disease over and the patient has been disease free for very many years. Those are the only condition where you could go and treat with curative intent, as the case is here. This patient was disease free for 7 years, presented with a solitary site in the proximal femur, had a fixation of the femur. So the take home messages are: recognize the fracture, evaluate it properly, diagnose it properly, look at MDT, look at histology, look at the number site of bone metastasis, look at.
Thank you, Dr. Anand.
Thank you.
And it was really a very informative talk, and there was a lot of information. And I understand that all these things have to be looked into account when we are handling a cancer case with metastasis. But let me ask few questions. If I'm not an orthopedic oncologist, I am doing my regular practice like an orthopedic surgeon. So I have few basic questions. Before that, because there was a lot of information, I just want to summarize for our orthopedic colleagues. So basically, if there is a pathological fracture which is related to neoplastic etiologies, it can be divided into 3 parts. One, due to a benign neoplasm. It can be a malignant like sarcoma, and the third is the metastatic. The most common scenario what we face is the metastatic scenario, which accounts for the most number of bone tumor cases. So in those situations, if there is a pathological fracture, a patient has presented to me in my OPD. You have given a lot of information, but I just want in few words. So if there is a lesion, what I need, if there is a pathological fracture of say upper limb in the humerus, and say it is around shaft humerus, and other scenario, a pathological fracture in neck of femur or proximal femur. So how do we proceed with that? What is, as orthopedic surgeon, what is my approach?
So Dr. Vivek, the answer is very simple. The pathological fracture, whether it's a proximal femur or whether it's a proximal humerus, the site is not important. What is important is histology.
Yes, very important. Yes.
First, you have to see what is the primary that is causing this fracture. Second, you have to see where are the sites of metastasis, whether it is only one in the bone or multiple in the bone. And second, whether there are any other sites of parenchymal metastasis or not. Based on these two things, and the third is availability of adjuvant therapies. Based on these things, you have to take a call whether you are going to treat the patient with intent of treatment is going to be curative or the intent of treatment is going to be palliative. If
Right.
you are going to render the patient disease free, you are going to remove the primary, and by removing the sites of bone metastasis, if you are going to render the patient disease free, then you have to go and treat with curative intent where you are resecting the bone metastasis and you are replacing the bone. If the intent of treatment is only palliative, where you are going to give adjuvant therapies and you want to palliate the pain or things like that, then you are not going to go and resect the bone. You are just going to go and fix the bone so that the patient can start ambulating or the patient can start using the limb. So that is
Okay.
going to be the modality of treatment.
Vivek, can I ask a question?
Yes, Dr. Manish.
So Anand, an excellent presentation. So just want to like ask you, like, is there any choice of fixation that you decide depending upon the type of histology? Like suppose we are having a pathological fracture, we know that it is from lung cancer or it is from prostate or it is from breast in a proximal third of femur or in the upper two-third of femur. Okay, so is there any difference in the healing rates that guides you to the choice of fixation? Like you want to replace one or put a nail in the other? Is that
So
decision
that
based on the histology?
So that decision could also be based on, I mean, it is obviously based on histology as well, but it is also based on, the extent of disease within the bone. Now, for example, if you said the example of proximal femur, if the bone is completely eaten away and there's very little to fix, obviously you're going to go and replace the bone. If there's going to be a disease in the lesser trochanter or somewhere thereabout where it's difficult to keratage it, fix it. So those type places, you're probably going to go and replace. So, I mean,
I
I
want
don't
to
have.
highlight, yes, one more point I want to highlight for benefit of everyone. So one, why histology is very important, because many a times patient, when they present to us in the OPD and they know that disease is widespread and there is some malignancy, the first question they ask us, what is the time I have? So, Dr. Manish, how do you respond to such queries? And if the patient has multiple myeloma, or if a patient has lung cancer with metastasis, how do you make out the difference
So
about
can
the
I, Vivek, if you
survivalship?
allow me, can I just share a slide
Sure,
for a
sure,
second? Yeah,
sure.
I think that can answer my question very easily, your question. So yeah. So can you see my slide?
Yes.
So the statement is the 6-month survival rate, Vivek, is different from prostate to breast to lung or kidney. So a prostate has a 98% survival rate, a breast can have a 89%, and a lung or kidney has a 60% survival rate. And myeloma, almost like all patients will survive more than 6 months. So, and with this, it is better to assume that the patient will live longer. Okay, so that is where and what that guides to our treatment. Like we have to assume that these are the approximate survival rate, and then accordingly you decide upon your treatment.
Yes. So one point that is coming up is for just for discussion that though the slides are shown in 6 month survival, but usually we talk about 5 year survival, and it varies from different histologies.
Yeah.
Coming to the point, like if the patient has multiple myeloma, so we know that the patient is going to survive much longer, and probably we can achieve remission with the drugs. Very important point what Dr. Anand had said is the number of metastasis that is present, apart from histology, whether it is a solitary or it is multiple. Because if there is a single lesion, then it has to be mostly biopsied to prove what it is. Because in a known cancer, previously known cancer, or with concurrent, we always, if there is a single bony lesion and no other site of metastasis, we have to prove whether it is from the same or it from the same primary, or it is a second primary which may be present. So that is one message that should be clear to all of us. Second, the choice of reconstruction that we are talking about. Uh, uh, there is, of course, what Dr. Anand said, that it depends upon multiple factors. One more factor that we have to consider is whether the tumor that is there, it is radio sensitive or not. Is it chemosensitive or not? So the sensitivity also helps in deciding the choice of implant. Coming about the choice of implants that we are going to use in a metastatic scenario. So that will depend upon basically the principles that what Dr. Anand highlighted, that we make a survivalship prediction based on certain scoring system. Like there is category scoring and different scoring systems are there, which helps us to predict survival in different histologies based on why he is emphasizing number of lesions, because the survivalship also decreases if there are larger number of lesions, if there is a visceral metastasis, which means metastasis to liver or lung or anywhere from the primary side. So everything decreases the survival. So we can predict nowadays, nobody is God. There can be exceptions all around, but this is the general data that is collected from different studies across the world, that a particular cancer, say breast cancer with a metastasis in liver and lung and bone metastasis will is expected to survive for these many months. So this is based on all these factors, we choose our treatment modality. Fine. So I think that was quite a lot about metastasis, and we can have more discussions on that uh, once the third topic is over. So I think without delay, I would like to invite Dr. Abhishek Srivastava. He's a senior consultant at Max Hospital and in the spine surgery department. And we all know spine surgery, the spine metastasis are one of the most common sites where primary tumors, they go and cause trouble. And all over to you, Dr. Abhishek.
And also welcome Dr. Arvind Jaiswal, who has just joined us. Thank you, sir, for joining us.
Welcome, sir. Welcome, Arvind, sir.
Thank you very much, Vivek, for having me over here. And Dr. Abhishek will take you through the pathological fractures and metastasis in spine.
Right, sir.
A very good evening to everybody. I would like to thank, first of all, Delhi Orthopaedic Association and Professor Maini in particular, and my colleague, Dr. Vivek, for giving this opportunity to present this talk in front of you. I hope you can see my screen. I hope you can see my screen.
Yes,
yes. It's
okay. And I would also like to thank Professor Jaiswal, sir, who is our head of the department, for giving me the responsibility to present this topic. So I'll be talking about pathological fractures in spine, and I'll give you a spine surgeon's view of how we look at these pathological fractures. So basically, as we had discussed earlier also, that pathological fractures are fractures that occur in diseased bone. So there has to be some underlying disease which is causing the fracture, and that is how you define them. So the primary causes of pathological fractures in spine are primarily metastasis, then the next come osteoporosis, and then you can have infection. And then there are other causes which include osteomalacia, metabolic bone disease, and other things, which have also been highlighted by previous speakers. But the main focus of my talk today will be on these three topics, which is mainly metastasis, then followed by osteoporosis, and then I will be briefly touching on infection, because these are all topics, big topics in itself. So coming to metastatic lesions of spine, they are far more frequent than primary lesions, though the love of most tumor surgeon lies in primary lesions, but unfortunately it is metastatic, which we have to deal with on a day-to-day basis. And the most common region for skeletal metastasis is spine. And as I told you, primary bone tumors are very rare. So I will, for the sake of simplification, call this metastatic spinal disease. So this is the third most common system after lung and liver to which metastasis takes place. And symptomatic spinal metastases are identified in about 10% of cancer patients. And usually 90 to 95% of metastatic spinal lesions are extradural. And the most common primary cancers that metastasize to spine are breast, followed by lung, prostate, kidney, and thyroid, depending on what literature you read. But mostly, commonly, these are the epithelial tumors which affect them. And the symptomatic spinal metastases are mostly found in thoracic region, followed by lumbosacral region, and the least in cervical region. So what is the most common symptom? The most common symptom is pain. It can be because of direct tumor invasion of bone, which causes an inflammatory effect. bony destruction, which leads to progressive loss of mechanical stability, allowing intervertebral micromotion in earlier stage, and frank deformity or kyphosis in later stages. It can also lead to tumor growth, can also lead to periosteal stretching, instability, and rest pain, which can, sometimes because of the above things, lead to neurogenic or radicular pain and sometimes neurology. So the end point of all this is impairment and diminished quality of life for these patients. The second most prominent symptom which we are concerned as, spine surgeon is neurological. So this is different from, most of the places because the nerve conductive tissues are very dense in these areas in form of spinal cord or cauda equina. So the most common the major presentation which we are worried about is paralysis or paraparesis. And usually it is because of mechanical, when there is a direct epidural tumor compression or due to bony compression as a result of a fracture, usually a burst fracture where the posterior wall is ruptured and it goes and presses on the spinal cord, or spinal instability leading to vertebral collapse and increased kyphotic deformity. The second one, which is more sinister, is called as vascular, when there is a, ischemic insult to the cord and that has got a poor prognosis. And usually it is sudden and the paraplegia or neurological deficit is dense. So management of instability, which is associated with pain and prior to neurological compromise, is the optimal time for surgery if it is technically viable. And then there are presentations where there is no frank motor deficit, but there are radicular symptoms like you can have in degenerative diseases or claudication symptoms because of stenosis caused by the tumor tissue or because of the changes which happen in that milieu because of instability. So how to proceed? I think we already have a detailed talk, but I'll just, for the sake of completion, go through that. You have to do a thorough clinical assessment. You have to take systemic history. You have to take neurological history, exactly when the especially in cases of neurological deficit, you have to exactly ascertain the time when it started. And if you can ascertain what is the primary tumor, and also the treatment taken so far, whether chemo has been taken, radio has been taken, or whatever treatment has been taken, then you have to examine the patient, and a neurological exam has to be done, and respiratory and breast, abdomen, we have to check all these systems. And also we don't have to forget to do a PR and a perianal examinations, because sometimes these things can give you vital information. So these are the basic symptoms which are suggestive of spinal metastasis, and these are the neurological symptoms suggestive of spinal metastasis, which can include radicular pain, limb weakness, difficulty in walking, sensory loss, bowel bladder dysfunction, signs of spinal cord or cauda equina compression that I have already told you. And before that, the pain can be in thoracic or cervical region, progressive, unremitting, and the pain which is aggravated by straining. There is localized tenderness, and if a pain which wakes you up at night, that is also a very significant indicator and suggestive of a spinal metastasis. So what are the investigations? You have to do all the routine investigations, and if there is already a primary known, then you can have a specific tumor markers to ascertain the disease activity. Or otherwise, if you are having a deficit, then you have to go for an MRI scan. So when do you do an MRI scan, and how frequently you should ask for that? If there is a neurological deficit, then I think you should, and you are planning an emergency surgery, then it should be done as soon as possible. If there is no neurological symptom, but there is a spinal metastasis and pain, usually within 24 hours you should go for it. And if it is just a pain, then within 1 week. So that is how we ascertain the timing. And also always try and look for the primary, because that is the one which is going to guide the treatment of the metastasis. How you deal with primary and how the primary behaves is ultimately going to have the bearing on the outcome of the patient. So when you look for the primary, you can go for PET CT scan. In centers where PET CT is not available, you can go for CT chest, abdomen, pelvis. You can do a chest X-ray, you can do ultrasound abdomen, and always liaise with oncologist before planning definitive treatment for tumors. That is something which has been internalized at most of the organization which deal with high volume of tumor. And the oncologist can help you in a lot of ways, as already it has been told by my previous speaker, who has highlighted this aspect of management. So what are the treatment goals? The treatment goals are to obtain a definitive diagnosis, if possible, either through a biopsy or preoperative workup. In absence of neurological deficit, then you have time, then you can do all these things. Then, you have to stabilize the spinal column if there is any instability, and you have to preserve neurological function and also alignment of the spine. And ultimately, you have to treat the primary tumor which has led to metastasis. Otherwise, this will keep on happening. So what are the indications for surgical intervention in metastatic spinal disease, where the role of radiotherapy is limited? So when there is an established spinal instability, when there is a pathological fracture, which is causing significant pain, and when there is cord compression secondary to fracture or bone retropulsion, and in radio-resistant tumors. Also, when the onset of significant neurological deficit is within a short duration of time. Elective surgery in a patient with a reasonable life expectancy is to be done to improve the quality of life and also to relieve troublesome symptoms such as pain. Surgery is usually not considered in patients with less than 3 months life expectancy, but there are exceptions to this. So this is the timeline where you can see how the treatment for metastatic spinal disease has evolved. So basically, when we begin with 1900s, it was an era of inappropriate surgery, where people didn't know what they were doing. Sometimes people will just do a laminectomy that will create instability, and then there will be sudden deterioration in the neurological deficit, and therefore it fell into disrepute. Then the era of radiotherapy came, and in radiotherapy, things started improving over a period of time from 1950, and then it became the mainstay of the treatment. Then from 1980s onwards, there was, re-establishment of surgeries. People started looking at surgery along with, radiotherapy. But the breakthrough came around 2005 when the Patchell, published his randomized control trial. And that is where it was conclusively established that the role of surgery along with, other therapies gives a better outcome. I'll come to that paper because that is an important paper we need to know more about. So Patchell was the first one who conducted first randomized control trial comparing radiotherapy alone to decompressive surgery followed by radiotherapy. In both arms, about 51 patients were recruited. And these are the main findings. 84% of the surgery group maintained ambulation for a significantly longer period compared to 57 of the radiation only group. Of the non-ambulant at commencement of treatment, 62% in the surgical group regained ambulation versus 19% in the radiation group only. The surgical group also showed statistically significant advantage in neurological improvement, pain improvement, and maintenance of bowel and bladder control. The median survival was better, and morbidity was higher in radiation only group. And subsequent meta-analysis have echoed these results. So as I've told you, just visiting the indications of spine surgery. It's spinal instability, progressive deformity, neurological deficit, isolated metastasis, and primary tumors of the spine. First and foremost, as I have told you, the mandate should be clear. The anticipated improvement in quality of life from the surgery must outweigh the risk. We call it risk-benefit ratio, and there should be clear-cut advantage to the patient for going through and ahead with the surgery. And also these significant complications have to be considered, like immunosuppression, poor nutritional status and medical comorbidities before deciding. So this is the role of surgical management. As I have already told, it is mainly, it can be diagnostic also. It helps to preserve, maintain mechanical stability and cord decompression. So what considerations do we have to take in decision making? Usually the lifespan of the patients, general medical condition, number of spinal levels involved, age, cancer type, radiation status. And as I've told you earlier, quality of remaining life is of great significance in treatment decision. And therefore, this is one of the system which, we use, which is called as Tokuhashi scoring system. It helps you give an idea of, how long the patient is going to survive. And therefore, you can decide the aggressiveness and also whether a surgery is needed or not for the given set of patient. It can act as a very good guide. So what are different kind of tumor surgeries? You can do anything, right, from decompression, front, back, both. But now, you have to stabilize them. And, you can do an anterior column stabilization, you can do posterior column stabilization, or you can do both. Now the trend is moving towards doing a posterior column stabilization and doing anterior column, work from the posterior only. And fusion also, if the life expectancy is more than 1 year, then, it is better to fuse that area to improve the longevity of the implant construct. So next comes the honeymoon period. I mean, it's a term which I'm sure all the married people are aware of. So it refers, but in spinal metastasis, it refers to the period after surgical decompression before the residual tumor can reproduce symptoms of cord compression. So before the tumor regrows and it encroaches on the neural tissues, that is the time which is called as honeymoon period. So the moot question is the honeymoon period just a phase or can you make it last? I mean, that goes for the same in life also, but we know what's the answer in life. But here we try and strive hard as much as we can to make it last. So the aim is to prolong the honeymoon period. So therefore, combination of surgery, open or minimally invasive, followed by radiotherapy is presently the most preferred and popular treatment modality. And therefore, the advent of stereotactic radiosurgery becomes important along with minimally invasive surgery. So because of the stereotactic surgery, there is now a concept, rather than doing an en bloc resection, you go for a separation surgery, which creates a gap between the spinal cord and the compressive tumor so that you can do radioactive, radiation therapy in that area without affecting the neural integrity or, harming the spinal cord. So this is the most preferred treatment. This is a sheet which gives you, how to manage a metastatic spinal disease. So if there is no neurological deficit and there is radiological compression, then, you can either do a stabilization if it is radiotherapy or chemotherapy, resistant tumor. If you are uncertain histology, then also you can do surgery. But if it is sensitive to radiotherapy or chemotherapy, then you only give that. And if the spine is not stable, so spine is stable. So SIMS is a score again like Tokuhashi for assessing the stability of the spine. So all the time you have to take care of the stability of spine, whether the spine is stable or unstable. If it is stable, then you can go for radiotherapy and chemotherapy. If it is unstable, then you have to operate and fix the spine. So again, when you go to the neuro deficit aspect, if there is a radiological compression, then, you have to do the stabilization. If there is no radiological compression, then you have to think about other things like vascular and ischemic insult. I mean, you can go through this chart. It is a very detailed one and it can help you in planning, the treatment. So this is a case example, 58-year-old female, back pain and radicular symptoms with mild quad weakness, kidney operated in 2009, 2010, radiotherapy for pelvic mets, MR spinal mets. There is an L3 lesion which is there and that is pressing on the cord. And it's not actually a single lesion, you can say, because already there are metastases, but in the spine, this was the only lesion and life expectancy was good. So after discussion with the oncologist, the embolization was done because renal tumors are, metastatic tumors are known to be very vascular. So first stage L1 to L5 posterior instrumentation and L3 posterior decompression and debulking was done. And then second stage corpectomy and reconstruction was done. So as you can see, first the posterior screws were placed, all the decompression was done from the behind. And then, we went in the front and then did a decompression and placed this cage. And the patient did well after the surgery. So this is another renal cell carcinoma patient with mets to spine at T4 to T5, good life expectancy. Again, here you can see a posterior instrumentation was done, laminectomy was done, the bone was resected and a separation surgery was done. But the filled gap was filled with cement. And this is what you can see. It is a technique whereby which you manually pack the cement in the body which you have resected. The patient was doing well at 2 years follow-up. This is the follow-up X-ray with full return to activities of daily living. This is a 55-year-old man. You know, sometimes some patients, when you do a, treatment with a curative intent. So like, in multiple myeloma with radiotherapy and chemotherapy and stem cell therapy, this patient had remission. But because of these things, he went into kyphosis. So as you can see here, his spine is bent all around like a question mark. And the bone was very weak because of the radiotherapy and things. So the surgery was staged. So first stage, cemented screws were done from T2 to T7. Second stage was vertebroplasty again was done from T9 to L1. And in the last stage, the T2 to L3 construct was done and the deformity was corrected. So as you can see here, now very good alignment is seen. Cemented screws are done. But we have to be careful when we are using cemented screws because, over a period of time, it can lose the hold and, you can have a problem. But if the bone is very weak and you don't have any other option, then this is something which you should keep in your armor. So coming to the next topic, that was metastatic spinal disease. Now the next etiology, which is most common, is osteoporotic vertebral compression fracture. I'll be briefly touching on this. So first thing is that etiology should be clearly established, and osteoporosis is a diagnosis of exclusion. So therefore rule out malignant or other benign causes. Aside from tissue biopsy, radiographic profile is often diagnostic. So these things should be kept in mind when you are dealing with a vertebral compression fracture. So as you know, in X-ray, there should not be any bony destruction or pedicle involvement. MRI, you should have normal signal intensity in T1. I mean, this is something which we have to really understand, that for looking at metastatic spinal cord compression, we should always look at T1 scans because that is where we can find the first, infiltrations. Whereas in osteoporotic fracture, T1 scan may not be that important. So these are the other features which suggest malignant etiology, which include convex posterior bulging of vertebral bodies, diffuse low signal intensity within vertebral body and posterior elements on T1 images, epidural or paraspinal mass, diffuse high or inhomogeneous signal on T2 images, diffuse high or inhomogeneous signal intensity after gadolinium injection. So treatment is ideally prevention. That is the most important thing. You should counsel all the elderly patients to take care of their bone health, get DEXA scan every 2 years and take appropriate treatment. Now there are various modalities, medical management is very good. And also fall prevention is a major aspect, which I'm not going into right now. So most of the the good news is that most of the vertebral compression fracture because of osteoporosis can be treated conservatively with analgesia, bracing and bed rest. Pain generally subsides over a period of 6 weeks following an acute fracture. And the absolute indications for operating on them, if there is any neurological compression like cord, conus, cauda equina compression with associated symptoms. Relative indication is severe disabling axial pain, and which is interfering with mobility of the patient, putting them at risk for additional medical comorbidities such as pneumonia or decubitus ulcers, bed sores. And if there is a severe deformity or if there is a neural compression because of non-union or anything which leads to spinal stenosis at that level, or because of retropulsion which leads to claudication or neurogenic symptoms. So these are the options of management: vertebroplasty and kyphoplasty. They are good for acute pain relief, but the Cochrane trial recently shows that there is, when compared to sham procedure, there is moderate to high evidence that it is as good as a sham procedure. So we have to be careful when we are offering, vertebroplasty or kyphoplasty to the patients these days. It also must be recognized that it will not correct the neurological compression by bone fragments or severe deformities. In fact, it is contraindicated in these situations. And then open intervention. This treatment, should be reserved for patients with neurological compromise or severe deformity. And here multiple fixation points are required to correct, because implant failure is a big problem when you are dealing with this. And also the new thing which has come up is minimally invasive or hybrid techniques. So this is, these are various approaches which one can take, for dealing with an osteoporotic vertebral compression fractures with neurological deficit or painful spinal ailment or with rigid deformities. So this was published by us in a book which is an osteoporosis of spine. So this is an example of a kyphosis correction in osteoporotic fracture. So this patient had a osteoporotic fracture at D12 and L1. So she developed a fracture and subsequently she went into non-union and progressive deformity. She was in severe pain and suffering. Her activities of daily living were severely restricted, and we did a posterior surgery and placed a cage in the front where the pseudoarthrosis was, and she returned back to her activities of daily living. This is just an example of, and also whenever you are doing these types of surgeries, you should always take biopsy. We'll always take biopsy from these lesions and send them for histopathological examination, because sometimes you might be surprised. So this is another 55-year-old female complaining of bilateral buttock pain with bilateral foot drop. So this is the X-ray. As you can see, there is degenerative scoliosis. And then we got the MRI scan. As you can see, there is a cleft here at D12, and then there is compression on the spinal cord. Also, there are multiple stenosis lower down the spine also. So this patient was, you can see the axial scans, and then this was planned. So we did a long construct on her, and this is the final outcome. Over a period of time, 6 months, she gradually recovered and regained her mobility. So now coming to infections, vertebral osteomyelitis, discitis, epidural abscess, or TB spine, which is the most common problem in our country. And in history, you should actively look for any immunocompromisation, other medical comorbidities, drug abuse. In investigation, always send routine blood tests, including blood cultures. If you are suspecting a septic etiology, like, acute bacterial infection, cultures from blood and urine should be sent, inflammatory markers, and look for a possible foci. MRI of whole spine with contrast should be done to rule out skip lesions. I mean, if there is a cost constraint, you can do a focused MRI of that area and a screening of whole spine. We always do a screening MRI of whole spine in our practice so that we don't miss any other lesions. And do not start antibiotics unless clearly septic. You should think and look at it before you actually commit to any antibiotic, because of the antibiotic abuse, and also you might not be able to get a proper diagnosis. So do a culture, do a scan, aim for biopsy and culture whenever possible, especially in TB spine, and always liaise with microbiologists and infectious disease guys for antibiotic therapy. So indications of surgery, it's like more or less, everywhere. You have to preserve stability of the spine, you have to preserve the neurological integrity, you have to get a diagnosis. These are three things which are sacrosanct for every, basic spine pathology. So progressive bone destruction, oblique failure to respond in spite of adequate chemotherapy, that is one indication. Evacuation of abscesses when it has increased in size in spite of rest and chemo. Uncertainty of diagnosis, mechanical instability, prevention of severe kyphosis in children, where from the previous studies that the kyphosis is going to progress, and spinal cord compression. Treat urgent surgically if progressive neurological deficit. Don't wait for too much of information to get, to accrue to you before you decide on the surgical path, because there is a very small window. If you have a complete deficit and you operate after 24 to 48 hours, then the neurological recovery might be very poor. So also, having said that, remember that infection is a medical disease. No matter what you do surgically, you have to treat the infection by medical means. Be it TB, be it bacterial, be it fungal, you have to give appropriate anti-chemotherapy. I mean, whether you give antibacterial, anti-TB, or antifungal. Surgery may not be always required if there is no instability, if there is no compression on the spinal cord, and you have a culture which gives you a good bacteria and you get an antibiotic which is sensitive. So this is an example, a 15-year-old male, multifocal thoracic tuberculosis with kyphosis and large pre and paravertebral abscess. He took ATT for 4 months. There was progressive kyphosis, pain, and there was compression on the spinal cord as evident by brisk reflexes. This is a posterior percutaneous. This is a hybrid technique where we put pedicle screws top and bottom, and then we use X tubes to decompress the part of the pedicle as well as the anterior body and place a cage in the front. That is how you do a pediculectomy and you go into the disc space and remove the compression. That is how it is done. And then you can place a cage. You can see here a peak interbody cage. You can see the markers. These are the markers here. And then you get a good correction. This is the post-op follow-up. The kyphosis has corrected and resorted to normal physiological kyphosis in that area. So this is another case where, there is a tubercular abscess with spinal cord compression and kyphosis. As you can see, there is a pus epidural component which is compressing on the spinal cord. This is a girl, 11-year-old girl who came to us with paresis initially and subsequently became paraplegic. We had to do a urgent surgery for her, and thankfully, after surgery, she recovered over a period of 6 to 8 weeks, along with concomitant anti-tubercular therapy. This is an interesting case which I want to share with you. This is an important learning for you. This is an 11-year-old girl which presented in casualty with weakness of right arm and pain in neck with deformity without any history of trauma. There was some history of low-grade fever. As you can see here, you can see a collapsed vertebra 2, 3, 4 at C4. And then the MRI was done because there was weakness in the arm. As you can see, there is a significant pre-vertebral component as well as, an epidural component which is pressing on the spinal cord, and also a lesion which is there all around encasing the vertebral artery. So, because there was a neurological deficit which was acute in onset, we went ahead, but the primary working diagnosis in our head was of probably a tubercular infection. So first, we did an anterior decompression and corpectomy along with plating. That was the first stage. So as you can see here, the first stage was done. The tissue was sent for biopsy. And once the biopsy came out to be eosinophilic granuloma, then subsequently it was decided to reinforce it posteriorly also. The patient was referred to oncology team and and subsequent workup was done. So this is the follow-up, which is, you can see there is good canal decompression and the alignment is maintained, and also the cage showing that there is good fusion across the level. This is the final follow-up after 1 year. And this is the follow-up scan after 1 year, where you can see that there is a bone formed through and through. This patient was under the follow-up of oncologist for a very long time. She received radiotherapy also and, some amount of follow-up with them. But patient made full neurological recovery and she, went on to do whatever she wanted. So this case highlights, especially in India, that you don't have to assume everything to be TB. Please do not forget to send a biopsy because that can give you a final diagnosis, and sometimes the final diagnosis might surprise you. So that is the most important takeaway which you can have. Thank you very much. Thank you for patient listening.
Thank you, Dr. Abhishek, and wonderfully concluded all the major indications and relative role of surgery and radiotherapy in spinal fractures. So do we have questions for Dr. Abhishek, or shall we move ahead with our case presentation?
Vivek, I have questions.
Yes, please,
I
Dr.
have questions. Excellent lecture, Dr. Abhishek.
Thank
So
you.
I had few queries / comments or questions. First thing is like this Tokuhashi score. This is a small comment. It was actually published in 1989. And at that time, there was not much medical oncology options, treatment options for lung cancer, in which it is scored as 0. Now, over the years, like we have significant options in the lung cancer, like we have a mutation, EGFR mutation, L-cross mutation. The outcome actually has changed for the lung cancer. So, do you still feel that this Tokuhashi score is valid, or just a minute, or do you take opinion of your medical oncologist before going ahead with that taking a decision based on this score?
So I'll tell you, first of all, it's a team effort. That's what I have emphasized. And the oncologist has to be involved until unless it's a neurological emergency. Then, I have to I cannot find an oncologist overnight. It's difficult to get hold of them. You have to go and fix the spine and decompress and send the tissue for biopsy. But if it is a possibility where you can have a option of, getting a oncology consult, then definitely we should go ahead. And also Tokuhashi score has also been modified. I mean, I am aware of recent articles in 2018. Some Chinese people have said that, in lung cancer, it does not represent everything. But I think it is a very good rule. There are certain rule of thumb or heuristics which we carry in our head, right? So that is a very good tool to get a rough idea of where we are placed. We can fine tune the course over a period of time by involving somebody else or somebody, oncologist and, even pathologist and things like that. But at your personal level, you should have something to guide you. How are you going to counsel the patient? You can't sit in OPD and, say a patient that I will wait till the oncologist says how much it is there. So you should have something in your head which can give him a range of possibilities. So you are not going to, counsel a patient exactly that this is going to be done, but you have to give him a range of possibilities, and this score helps you arrive on that. And also Tokuhashi has been modified by various people. And I think last modification was done in 2005. And subsequently, as I told you, recent criticism has come for lung cancer. But still, I think it is a very good working tool. Obviously, if you can find something, fine tuning, it's always better to get other opinion.
Another small question, like you have actually emphasized on the role of radio surgery in spinal metastasis, which is a stereotactic radiation. So basically, do you encounter more spinal fractures after stereotactic radiation? Because what we only need is a palliative RT, which can be given in 30 gray 10 fractions or 20 gray in 5 fractions, or a single fraction of 8 gray. So by giving a higher dose of a radiation to a particular vertebra, do you encounter higher number of fractures? Because usually what we are dealing with a multiple spinal metastasis. We are not dealing with a solitary metastasis, and what we are looking for is an expected survival of 1 to 2 years. So do you really feel that the radio surgery is like a tool which we use very often in a metastatic spine disease?
Well, I think as either you told or Dr. Raja told, right? Always assume that the patient is going to live longer. And
I only told, but we cannot assume a patient to be living for 20 years with a metastatic spine.
That's what
we have to be practical also about it.
Yeah. So I think that, radio surgery definitely helps, and I don't think it increases the chances of, fractures, adjacent fractures, anything. I don't think that any paper which has conclusively looked at.
I think there are papers. I think there is a data that the higher dose, the SPRT increase the spinal fractures in metastatic disease. I am aware of few articles. I am not very sure, but yes, I think there is a data.
But I don't think
we also have Jaswal sir with us. Sir, would you like to share your experience with us? Jaswal sir.
On these scoring systems, as Dr. Abhishek said, and Dr. Manish, I agree with you. You have to modify them. But what is most important is the quality of life. Even for those cancers who have a short lifespan, the quality of life is what is very, very important. In that short span is very important. And as Abhishek said, you move from the conventional part depending on the patient, and as the oncologist and we usually have a tumor board decides. So few exceptions that you make, and the improvement in surgical skills and instruments have helped you. Minimally invasive surgery, which Dr. Abhishek touched upon, is one such tool. Even for multiple metastases, as you said, just fix them in half an hour, 45 minutes, percutaneous fixation. Let the patient be up and about, and then you can get into your radiotherapy and advanced radiotherapy group, right? Number two, you can also, in neurological deficit, you can do a small decompression through the tube, which Dr. Abhishek said, and then get the tumor guys to come in and do it. So you got to be flexible and depending on the patients, and advancements will keep on happening, and we have now tools to make the patient more comfortable. and a better quality of life.
So
Thank you, sir.
exactly, sir. That is what I wanted to highlight. Sorry, Vivek. Sorry to. Okay, because Tokuhashi actually falsely labeled as lung cancer into a very poor group. But over the years, the outcome in the lung cancer has actually improved. So that is why, like, we need to actually be more proactive in managing these metastatic spine disease, even in lung cancer. That is what I wanted to highlight here. That lung cancer, although it scores at 0 and a very poor Tokuhashi, but that was in 1989. So in
Yeah.
2021, there are multiple options in lung cancer which actually can change the outcome. So that is what first I wanted to highlight. And Vivek, I have one
Yeah,
more question if you allow me.
Yeah,
one more point
we
on
are
Manish on this.
Yeah.
Okay. If I can just quickly say,
sure, sir.
these Tokuhashi score basically was really designed to differentiate radical surgery, means an en bloc
Absolutely.
resection, which would take 8-10 hours, versus it also gave you scope to do a palliative surgery, means fixation and small decompression. It gave you that score. So one, you do not have to be sacrosanct about it. And if the
Yeah.
prognosis of certain types of cancers is improved with radiotherapy and chemotherapy, that score, that sort of flexibility is still with you. You can do a conservative sort of a surgery on these, right?
Yeah.
Rather than do an extensive, very high morbidity surgery as
Yeah.
such.
One more question, sir. Can I ask?
We can
So,
quickly
so,
just wind up this session
so
so that we can.
Doctor, yes. So, Dr. Abhishek, you have shown two cases of kidney cancer where you have done a radical excision. So, like in kidney cancer, what we are doing is either a radical excision or a debulking surgery. So, did you follow that WBB system for a radical excision? Whether the radical excision was possible, or we just debulk the tumors? If we have just debulk the tumor. So, we have Dr. Anand Raja here with us currently. So basically, I
Dr.
want to ask
Yeah,
whether
I'm here.
So Anand actually manages the Euro unit also. Anand, does that actually help us in the management of a kidney cancer?
Yeah, in management of kidney cancers, like I said, there are two issues here. One is after whether you've got one metastasis or two metastasis, if you can do an R, if you've done the nephrectomy and you do an R0 resection at the primary site, at the metastatic site,
Yeah.
then it is useful, because if you render the patient potentially R0, then the patient is not a candidate for adjuvant TKIs or adjuvant immunotherapy. The patient doesn't get immunotherapy until progression. But if you've not removed the kidney, or if you've not removed the kidney, then removing en bloc resection of the spine doesn't make sense. If you've removed the kidney, but if you've only done a debulking, if you've left behind microscopic or gross disease, then the patient will need adjuvant, tyrosine kinase inhibitors or immunotherapy. So, I mean, it's not just implication. If he's R0, no further therapy. R1 or R plus needs adjuvant therapy. So that's the implication.
Right. So we need to stage the disease and select our intent of treatment, whether it is going to be a curative or palliative. And depending on that, we have to select the choice of surgery. Fine. Just one point I would like to add up what Dr. Abhishek was talking, very interesting point about honeymoon period. And we know that to prolong this honeymoon period, mostly we think about radiotherapy, but nowadays we were discussing about chemotherapy, which has changed the course, and many pharmacological newer modalities like denosumab and bisphosphonates have been in use. So with this, we move on to the case-based discussion, and it's about pathological fractures case discussions. So we have Dr. Akshay Tiwari with us, who is the director, orthopedic oncology at Max Saket with us. And we have all the esteemed faculty members and Professor Jaswal sir with us. So before I move on to the case, Dr. Akshay, are you there?
Yeah, hi, Vivek. I am very much here.
Yes, great. So just want to ask you, because last week I was doing a session on orthopedic oncology and somebody asked this question. Why do you say that we should not plate a femur or we should not nail in a sarcoma, what is called rhodoid sarcoma? Manish also said that if you put a nail or if you do a plate, then patient ultimately had to go either a very morbid surgery or amputation. So what is the logic behind this? What is the thought process?
Yeah, so basically, as was told in both the previous talks by Manish and Anand, sarcomas have to be treated entirely differently from metastatic disease for the simple reason that ultimately they are going to require complete excision, which is going to be an excision with wide or radical margins. And whenever you end up fixing a fracture which has happened through a sarcoma, ultimately you're going to contaminate the whole field, whether you have plated it. If you plate it, then you end up contaminating the soft tissues. If you nail it, you end up contaminating the whole medullary canal. And that makes the job of a wide margin excision of a sarcoma entirely either difficult or absolutely impossible. And that is why these patients end up getting much more morbid surgeries than what they would otherwise have gotten. So
Yeah.
the
Please.
thumb of rule is that you just splint them. If you think it could be a sarcoma, even in the remotest of possibilities, you just splint them, get to your diagnosis, and then think about whether to fix it or to send it for chemotherapy.
Right. So I'll start with this case presentation. And first case is a young man who had pain in the knee for 2 months. He was initially worked up elsewhere. Blood investigations were normal. I'm not going into very basics of reading the X-ray, but Dr. Manish, if you have a patient with X-ray like this, what is your approach? You are in your OPD, patient has come.
So Vivek, this X-ray in a 23-year-old male definitely shows some permeation in the metadiaphyseal area of the lower end of a femur. And although it is not very clear, but there looks like some interrupted periosteal reaction. So I will label it as an aggressive bone neoplasm, and
Okay.
I will take it from there. Okay, I cannot ignore it. This looks like an aggressive bone neoplasm. Can be infection, can be primary malignant tumor.
Okay. So broadly, when we look at X-ray, the differentials usually are between neoplastic etiology, which may be either benign or malignant, plus versus an infection. So what would we do next if we have a lesion like this? Should we go for biopsy or we do
I
some
think
more investigation?
the standard protocol, any bone tumor after radiograph, we have to do an MRI. So we'll ask for an MRI of the full arm, full leg.
Right. So, but somehow the place where he was being seen, the doctor suspected that it is infection, started him on anti-tubercular because other parameters are all normal. He suspected it to be TB, and then he sustained this fracture. And what should be done here now if the patient has come with a pathological fracture? So this is a common scenario where most of us as an orthopedic oncologist, we have seen cases which undergo some sort of intervention in a pathological fracture.
So Dr.
Yeah, sorry. So this was done actually. This was done to him, not by me, somewhere else. So this was his presentation. And during doing the nailing process, biopsy was sent, and which turned out to be osteosarcoma. Now, this is the time when they realized that, okay, now the biopsy has come osteosarcoma, there is cancer, we need to look for oncologist. And the patient then came to me. So what is your thought process now? How we should have changed the approach and things in this case?
So same thing. I have also highlighted, Dr. Anand has also highlighted that there is no emergency of fixing a pathological fracture.
Right.
In the approach also and in the management also, both of us have highlighted that there is no emergency in fixing a pathological fracture. First thing is we can splint the patient and go for do a workup for a diagnosis rather than thinking of fixing the fracture. So now, as Dr. Akshay had already highlighted, we have contaminated many things. We have contaminated the knee joint, contaminated the soft tissue, and made the tumor spread into the medullary canal right up to the where we have done the reaming, which is up to the lesser trochanter at least.
Yeah. So whether we do a plating or a nailing, ultimately, whatever the tumor contamination is there, it tends to happen, and it should be 100% avoided in a sarcoma. Otherwise, it leads not only jeopardize a limb salvage surgery, but it is a threat to life as well. Because if the tumor is throws embolus, it metastasizes, and then the survival, everything becomes very poor. So if the patient has presented like this, so what would be your choice? It has contaminated the knee joint because the entry portal is there. Dr. Akshay, if you can see the imaging, you can comment on this. So we have trochanteric interlocking bolt was there. Lateral side, it was open to put the nail and probably reduce the fracture. So would you like to go for salvage or amputation?
So of course, number one, Vivek, the patient goes for neoadjuvant chemotherapy, and that gives both me and the patient time to, think about our options and what are the pros and cons of either approach. Now, suppose the patient, even if he responds to chemotherapy, we have to see whether we can completely resect en bloc whatever compartments have been contaminated. And here we can see the knee joint, the distal lateral thigh, and the whole of the canal, and also proximally the soft tissues for the interlocking have all been contaminated. Obviously, the surgeon has used the same instrumentation.
Right.
Generally, as a general rule, this patient will usually go for a hip disarticulation, as per me.
I'll just stop you for a minute because there was a similar question in the chat box. Somebody had asked, a patient had osteosarcoma with a pathological fracture. So I want to ask you, what is the crux before we decide between a limb salvage versus amputation? What do we look at?
Yeah. So, as was already mentioned by Anand, pathological fractures are no more an absolute contraindication to limb salvage for osteosarcomas. That is one. So, when we are considering salvage versus amputation, obviously the patient has been splinted and not fixed. He's got adequate splinting of the fracture, and he goes for neoadjuvant chemotherapy. If there is a very good response to neoadjuvant chemotherapy, usually these fractures will stabilize and even heal. And then we have to carefully go through the pre-chemotherapy and the post-chemotherapy imaging to see whether we can actually resect uh, all the area that was contaminated by the fracture hematoma. Now this becomes very difficult when the fracture has been surgically tampered with, because you have opened up the natural planes, and then you know that the hematoma has contaminated not just the vicinity but almost the whole of the compartment and also the canal. But in a fracture which has not been tampered with, just splinted, and has undergone chemotherapy with very good response, and you think the pre-chemotherapy hematoma can adequately be removed with wide margins with the tumor, it's okay to go ahead with limb salvage. If
Okay.
that is not possible, the hematoma was very widely contaminating all the compartments, or the fracture has not healed and in fact even progressed on chemo, then of course salvage will not be possible.
Right. Dr. Anand, would you like to add something to this? Or
I think you just spoken brilliantly. I mean, Akshay just said everything that needs to be said.
right. So yeah, so he presented to me with this scenario, and then the contamination had encased the neurovascular bundle as well, and so I had to do a hip disarticulation, modifying the flap, and he was started on chemotherapy. So the message is, if there is a pathological lesion, mostly either it is an infection or a neoplastic etiology. And why we always ask to follow the right protocols is because the treatment of a benign lesion can be somewhere from observation to extended curettage, like in GCT or chondroblastoma, or may require wide excision when reconstruction, even in benign tumors, may not be possible because of perforation, breach in cortex, pathological fractures, etc. Once it comes to malignant tumors or sarcoma, especially high-grade tumors, always have to be excised with wide margins. And it is not just about the surgery, but has to be treated with the multimodality management, which has been very, very importantly emphasized in his talk of Dr. Anand Raja. So if we look at the workup, how we should evaluate a pathological lesion, the first thing is to diagnose, then to stage, and then go for the management. Dr. Manish already highlighted that diagnosis is based on a correlation of our clinical findings, radiological workup, serological workup, confirmed with a biopsy. And then let us put this scenario. If he had presented to me, then how I would have managed. So first part was diagnosis, and Dr. Akshay said we should always splint it. A pathological fracture is not an emergency. Splint it, do the complete workup, X-ray, MRI. I would have done a biopsy from either lateral or medial approach, depending where the soft tissue was more. And then the diagnosis of osteosarcoma would have been confirmed. Then PET scan would have been done, or either CT thorax and bone scan, which would complete the staging workup. When he presented to me, he was non-metastatic in spite of the contamination. then I would have started on chemotherapy. And then this was a very nice case. This is the standard type of presentation through which these sarcomas present. And we routinely go for a limb salvage surgery. Even with such pathological fractures, we see that they heal beautifully well, and a limb salvage surgery could have been done. Unlike in this case, where because of the contamination, we had to go for a more radical and morbid procedure, which is a hip disarticulation. And we don't know what was the impact of that reaming. And it is only 1 year now following the surgery. We have to wait if it turns out to be metastatic or not. So the crux is that all pathological lesions needs complete workup. There is no shortcut to the diagnosis. Already emphasized, pathological fracture is not an emergency, and no definitive procedure before a histopathological diagnosis is made. Right. Coming to the next case. So this is a young lady who had pain in the thigh for 4 months, presented in emergency with a pathological fracture of the proximal femur. Dr. Anand, just can you quickly summarize here what can be done?
Again, just very similar to what Dr. Manish had, very similar to what Dr. Manish had said. There's a fracture, but there's no hurry to go and treat it. You can probably just go and splint it, and after that, do an MRI and take it from there.
Right. So, Dr. Manish, this is a metaphyseal lesion fracture. We can see that there is a loss of bone, and biopsy was showing plasma cells. PET scan was done, which does not show any other site of lesion, any other site of metastasis, and a diagnosis of plasmacytoma was made. What would be your treatment choice in such case?
Vivek, the diagnosis of a plasmacytoma is not only based on the PET CT, but based on the bone marrow aspiration biopsy report also. So I think even if we get a report of a plasmacytoma, this does not rule out multiple myeloma. Okay, unless we do a bone marrow and get a hematological evaluation. So I think once I get a report of a plasma cell neoplasm, even with a single lesion, the best thing is patient to be evaluated by a hemato-oncologist to rule out that whether the patient actually is suffering from multiple myeloma or a plasmacytoma. Okay, so a treatment of a plasmacytoma right, which is not fractured when we have diagnosed, got a hemato-onco opinion, a plasmacytoma which so a treatment of a plasmacytoma which is not fractured is a definitive radiation. But in this case, when the lesion has fractured, we need to fix it first. So in this case, I will do a nail and then give radiation.
Okay. Dr. Akshay, your opinion, same or different?
Yeah, I will agree because discussing earlier, how you approach a pathological fracture depends a lot on what the adjuvant is going to do to the fracture. For plasmacytomas, we know we have these excellent radiosensitive, excellently radiosensitive tumors, and almost all of them will heal on radiation. And in any case, the definitive treatment is for a solitary plasmacytoma is definitive RT. So fix it with a nail and then back it up with definitive RT. That will be a plan.
Yes. So similar, the same thing was done, and we can see how all the bone which was not seen, which was lost, responded so myeloma as well, which requires along with radiotherapy, chemotherapy. Fine. So coming to the third case, young lady, yes, 40 is young, anesthetist by occupation, presented with pain in middle phalanx. She was initially treated conservatively with splint for 4 weeks, but pain persisted, and since she was anesthetist, she had to intubate. She had constant pain. So looking at the X-ray, I'll just show the MRI as well. We can see that there is some radiolucent zone here. So Dr. Manish, in such cases, would you go for MRI or directly can plan for surgery or observation? What will be your take within phalanx if there is a lesion?
So Vivek, the problem is that if it is an incidental detection, I would not run an MRI. But now the patient is presenting with pain, she is symptomatic for it, and most likely she requires a treatment, and we can see a fracture also going through it. So it is better to do an MRI, which will give a much more qualitative evidence, what kind of lesion that we are dealing with.
Right. So MRI was done and it showed a chondroid lesion with endosteal scalloping and a pathological fracture. So generally, the treatment of enchondroma would be observation. Very rightly, what Dr. Manish pointed out, that in incidentally detected asymptomatic lesions. But since surgery is reserved for cases which are symptomatic pathological fracture or with impending pathological fracture. And in this case, we did curettage fixed with bone graft substitute and a plate. So I'm just rushing because we are short of time. I wanted to complete some cases. This is an interesting case. So I think Jaswal sir and Dr. Abhishek is there. So this will interest them more. A young man who presented with progressive weakness in lower limbs for 6 weeks duration. So he was initially seen elsewhere. I saw him much later on, but I'll just go through the pictures. This was the X-ray, and yes, there is collapse of D9 vertebra with cord compression. I spoke to the orthopedic surgeon who had operated, and he said that the patient had presented with acute deficit, and so with no bowel bladder involvement, and so he had to operate in emergency. My question, Doctor, okay, sir, is there. Arvind, sir, how will you approach if a patient has presented to you with neurological deficit with weakness in both lower limbs and with this imaging? Though the history of pain and deficit is long, he had a progressive weakness, but suddenly in last 2-3 days, he had incoordination in walking, and then he presented to the emergency. Sir, you are muted, please unmute.
So because of the severe neurological deficit, rather than going for a biopsy and things like that, you need to decompress the patient. How old is the patient? Sorry,
he's young, sir, 24.
24, right? So it seems to be a primary tumor rather than metastatic tumor. But even then, we would like to decompress it and do a fixation. Do a quick decompression and fixation without really going and do a biopsy. Ideally, we do a biopsy as a frozen section biopsy. It will give us some idea of the tumor that is there. So and then proceed accordingly what you do.
So if there was no neurodeficit, we would have gone for a biopsy proper, so that if in case if it is a sarcoma and we have to plan a radical excision with en bloc excision, that would give us time. But since this was a neurodeficit, in such situation, decompression and biopsy can be done in the same sitting. So the approach usually will be both combined anterior posterior approach. Okay, sir.
At first stage, when you're decompressing and you don't want to do you don't know the tumor pathology, you would like to do a decompression fixation to get the neurology, particularly address neurology, when you surgery accordingly, and also an embolizing and other things. Yeah.
Right, sir. So in this case, the surgeon who had did this decompression, and patient was all right for some time, like Abhishek had said, honeymoon period, and then started developing pain again. The biopsy which was
what was the histology?
Yes,
did we wait for 8 weeks?
Yes. No. The biopsy was sent that time, and it was giant cell tumor, but the patient was not sent for anything adjuvant. So now my question to Dr. Manish. So now this is the situation. There is a local recurrence as well. Before that, Arvind sir, was the decompression and stabilization, you feel it is adequate with such a collapse, or we needed more?
If you had to do a decompression, fine, you have to do an open decompression, sort of remove it, small decompression.
And in such cases, anticipating
supposing if this turned out to be metastasis or something. No, I just 1 minute. The reason why we would do a more definitive and more extensive fixation, at least 2 above, 2 below.
Right, sir.
And this tumor was somehow not operable and things like that, and you have to do chemoradiotherapy only. In which case your fixation should have been adequate. This is not adequate.
Right, sir. Okay, so Dr. Manish, GCT, if suppose the diagnosis was made of GCT after doing the decompression, by posterior approach, and if we look at the images which was there, so what we know that there will be residual disease behind. So whether we would have waited for honeymoon to get over, or should we have intervened with something?
Not at all, Vivek. So basically, we know that we have decompressed to preserve the cord function. Okay, but then there is a big residual disease which is there. Okay, and the best management where we cannot do a proper curettage of a giant cell tumor is embolization and denosumab, because that gives a certain chance of getting a cure from a giant cell tumor. So I think in this case, I will straight away start with embolization and denosumab and then see the response.
Yes. So there have been literature which has suggested that serial angioembolization along with denosumab many a times leaves the disease static, and especially in axial GCT where surgery is too morbid, radiation therapy may be reserved for cases which are refractory to this treatment. Uh, Dr. Akshay, my question is why we don't plan for radiation upfront? Why we are thinking, because it's easy, means if patient has come, we just refer for radiation therapy.
Yeah, so basically, there are more than one, Vivek. One is that it definitely is a benign disease, and there is, even if now not that much, but still a chance of a secondary sarcoma happening after radiotherapy. Second is that the chances of recurrence are still there even after radiation. It's not as if it's the best modality to treat a giant cell tumor. And these are the two main reasons we would generally not keep radiation as the first choice of treatment. Although sometimes you are, forced to have radiation as an option for treating GCT as well.
So thank you very much. And I think
can I just intervene?
Yes, sir, please.
Yeah,
please.
but in this particular case, I agree with you. We would also give now denosumab, and but then once after giving the denosumab, we would go in and do an excision anteriorly of the tumor. Because even with denosumab, giant cell tumors have been known to recur after 2-3 periods. They'll have a recurrence. So this is if locally malignant tumor, you cut down the size with denosumab, and it also encapsulates the tumor, and it's now amenable to surgery. So you go anteriorly and completely do an oblong resection and then stabilize with the cage. Young patient, it's worth doing a surgery, and the second stage after denosumab.
Right, sir. So unfortunately, this patient did not follow up. He just came to me for opinion, and I had given him.
Fortunately, Vivek, this patient was following up with me.
Oh, great! I am sure then something good have been done. What was done finally?
So fortunately, and then we did an embolization and denosumab, and now I think he's 2.5 years, and he is still having a stable disease.
Great, great. So I want to thank all of you. The time allotted to us was till 8:30, and I think this was a really broad topic, and with all the eminent faculties and speakers and our panelists, we were able to execute it in time. So I hand over to Maini, sir.
Thanks, Vivek. I think a very nice evening session on a very difficult topic, and nice of Abhishek to broadening the definition and touching upon the other things. We surely know that pathological fracture is in a diseased bone, and metastasis is one of the biggest worry. So anybody, if any of the faculty wants to say any parting comment or anything, any carry home message from anybody, Dr. Jaiswal, Dr. Akshay, Dr. Anand, anything you want to re-emphasize as a parting message on pathological fractures, which seems to be a place which now is being treated. It was ignored earlier, probably.
Yeah, so I think, Dr. Lalit, the take home today, the biggest take home has been that we have to be aware of the diagnosis before we embark upon fixing a pathological fracture. And that is something that has to be made more and more clear in the minds of all young upcoming orthopedic surgeons. And we have to look at the age of the patient and whether the patient could be a primary bone tumor or a secondary, makes all the difference in how you approach that fracture. I think that has been the biggest takeaway.
So can I add?
Yeah, Manish, sure.
Basically, sir, just want to highlight, like, do not presume that a fracture, a pathological fracture in a pediatric age is because of a benign bone tumor. And in an adult age above 40 years, it is because of a metastasis. So unless we are 100% sure based on the pathology report, like that is what we do an error. We presume that a pathological fracture in pediatric is because of benign, or in adult because of a metastasis or myeloma rather than a primary malignant tumor. And there we go wrong usually.
Excellent, excellent, I think. So we are also almost, yeah. Abhishek, anything you want to add?
Yeah, I just want to add the basic thing is that we should put across a message that this is a team effort which everyone has to, participate in. It's not we don't have to operate in silos. We have to, take it as a team effort.
Sure, sure. So I think it has been a great session, and it's a very good preamble to the sarcoma month coming up next month. Akshay had informed me that we are coming up with July as a sarcoma awareness month. Is that right, Akshay? So
Yeah, so July is Sarcoma Awareness Month, and we hope to have a couple of activities with the DOA and DMSOG
yeah,
and make people more aware of this entity.
yeah. So thanks from Delhi Orthopaedic Association to all the esteemed faculty on taking out their time and making this evening so interesting on this difficult topic. The next Sunday's webinar is going to be on meniscus. We're going to talk A to Z of meniscal pathologies. We have this habit of jumping from extreme, topics from pathological fractures to meniscus, and then from meniscus to DDH. So thanks a lot to all of you, and enjoy your weekend. There's a cricket match, and there is UEFA and Copa all going on. So have a nice evening. Thank you so much.
Thank you, everyone.
Bye-bye.
Thanks
Thank
to,
you.
thanks to the organizers. Thanks for inviting me. Anand here. Thank you so much. Bye-bye.
Thank you. Thank you.
Thank you, all the faculty members, for joining in. Have a great night ahead.
Thank you very much.
Bye-bye.
Thank you, Dr. Lalit. Bye.